Hello everyone, welcome back to a new session in dentistry and more. So we have question paper discussion on pediatric dentistry, and this will be the part 1 of many sessions, and we'll be having questions from various question papers of university exam, that is Kerala University of Health Sciences. So it starts with the first chapter, that is Introduction to Pediatric Dentistry. The first question was define Pedodontics and mention its scope. Explain the periodontic treatment triangle. Periodontic treatment triangle is a very commonly asked question, where a treatment triangle where the child is at apex and the family and the dentist are at the other two corners. So an adult requires a service to be carried out in his mouth, and if he is not satisfied, he will seek satisfaction elsewhere. Whereas a child attends the dental service because he is forced to do so. He is not coming by his own will. So the child will have to return even if he does not like the treatment. So what happens is we may expect the adult to put up with the unavoidable discomfort. Therefore, he has the freedom to choose his treatment and can also appreciate the outcome, whereas a child sees no good reason for dentist attention. So child is in a very dynamic state of growth and development, whereas the adult is in a very static state. So consideration of the behavior as an integral part of child oral health care and needs. So we need to highlight the child at the, or we need to put the child at the apex with the consideration of two other corners, that is family and dentist. Defined by Wright in 1975 and was later modified by McDonald in 2004, where the difference between child and adult with respect to the treatment was emphasized. So that was about periodontic triangle. So the first question was define Pedodontics and mention its scope. So that is also again coming up in the next question, where another question is added, that is put a note on the setting up of a pediatric dental practice, how the pediatric dental practice is differ from the adult dental practice or a regular dental practice. So when we go to a pediatric clinic, we can say it is totally different in its aesthetic, its appearance. It's more of welcoming for a child. So definition of Pedodontics, it is given in the textbook of Nikhil as it's an art and science and branch of dental science which deals with comprehensive interceptive oral health in children from childhood to adolescent age, particularly, and complete health in general. So what about the pediatric dental practice or pediatric dental design? Okay, so we need to think about the provision, space provision, and the play area, and regarding the front desk, waiting area, the attire and presentation of the clinical staff, the colors, smell, sounds of dental clinic, because every factor is going to affect the child's response or child's cooperativeness or child's behavior in the clinic. And we need to think about the instruction for children and their parents, and readiness to accept children, the gifts and awards we give, the audiovisual aids for entertainment, and design of equipment in the clinic. So every factor has an impact on child's behavior. Okay, so regarding the play area, it need to be very colorful. It need to have all the children's favorite characters or cartoon models. Front desk people should be very pleasant and very welcoming, and waiting area should be child friendly. And regarding the attire and presentation, they should wear pleasant colors. Regarding gifts and rewards, give a child a token of appreciation for good work with a small gift at conclusion of a visit, such as dolls, pencils, medals. And never bribe the child before treatment. It should be given only after the treatment. And also regarding the audiovisual aids, and it should be like the TV set in front of the dental chair can distract the child enough to forget the dental treatment. Okay, so and children forget themselves while watching the cartoon films. And once the child is cooperative, it reduces the need of talking on the part of dental team. It is good idea to have a camera attached to a TV displaying the child on the chair, as children to love watching themselves. And design of equipment is also important. A sufficient number of instruments, mouth props, and other restraints should be there. Regarding the design of equipment, it's very important. A colorful towel to cover the restrained child, a camera to take first examination photograph, all should be there. The equipment must be accommodated to the child, not vice versa. And the dental chair can be modified to look like a cartoon character, or any innovation is acceptable where the child is having a very cooperative environment in the dental clinic. Now we have a concept that is dental home. So dental home is a concept and it is defined by American Academy of Pediatric Dentists as the dental home is the ongoing relationship between dentist and the patient, inclusive of all aspects of oral health care, delivered in a comprehensive, continuously accessible, coordinated and family-centered way. So establishment of a dental home begins no later than 12 months of age, and it includes referral to dental specialists when appropriate. So regarding the ideal characteristics, I have listed it out, like should be accessible, should be family centered, should be continuous, comprehensive, coordinated, compassionate and culturally competent. And what are the advantages of dental home? That it embraces the importance of early intervention with optimal preventive strategies, and it encourages the first dental visit by approximately 1 year, and the practitioners can provide personalized preventive approaches for children based on their family histories, and the oral examination and the risk factors can be identified, and the preventive intervention can be personalized to the needs of children. So that was about dental home. Now we are into the pediatric dentistry, that is definition and scope of pediatric dentistry. So definition given by Stewart, that is the practice and teaching of comprehensive preventive and therapeutic oral health care of a child from birth to adolescence. So what are the scopes of pediatric dentistry? So integration of appropriate didactic and clinical knowledge from various specialties into a framework of quality healthcare for the children. So pediatric dentists have extended services to fulfill the need of a special child, including physically, mentally and medically handicapped, and it concentrates or it branches out to all other specialties because it includes preventive, interceptive, orthodontics, preventive resin restorations, and the remodeling process, that is orthodontic treatment regimens. So everything is involved, so we just cannot isolate a pediatric dentistry as specialty because it has branches in all other specialty. Even in the pulpectomy, it's more of a endodontic therapy. So it is virtually includes essence of all branches of dentistry like diagnosis, oral surgery, rehabilitation, endodontics, orthodontics, preventive dentistry, and also includes a new era like new technologies like lasers and nanodentistry. So that was scope of pediatric dentistry. Now all of you know what is infant oral health. That is how it is important for the general health, because a good teeth which is taken care well at the beginning time, the patient or the child, when he becoming an adult, there won't be much problem. So prevention is always better, and always it saves lots of money, time and pain. So a caries can be intervened at a very early stage. It will be a very small cavity, it can be easily filled without any pain. As the time goes without any intervention, what happens is it reaches to dentine, pulp and periapical infection, and it also affects the permanent tooth bud, and it again complicates things. So early intervention can be done. So it is also helping for the child to have a very good set of teeth without any problems in the future. So that is infant oral health and its importance. And diagnosis and treatment planning, that is, the question was define dental age, mention the sequence of eruption of primary and permanent teeth, and briefly describe its importance. So dental age estimation is very vast topic. It is estimated according to the last tooth eruption in oral cavity. We have Demujian method, Norlas method, Johnson's method, Massler method. So all methods are there for age estimation, and we know how the primary and permanent teeth are differs in its size, in its color, its number, the shape, the number of grooves, the depth of grooves, and well sharp pointed cusp in permanent teeth, but it's not there in the primary teeth. And the size, the primate space, the leeway space, and the end-on relation, the molar to molar relation, so everything. So you can differentiate based on many things. The every aspect is different: enamel, dentin, cementum, root, the alveolar size, the alveolar arch, the color, the shape, the translucency, everything is different. Even the number is different, 20 and 32. Next we have the guidelines for prescribing radiographs for children, and add a note on 4 film survey. That is important. So the techniques are same, but only the thing is X-ray film is different. X-ray film, and we need to emphasize on reducing the anxiety and reducing the number of films. We can't go on repeating for get a best IOP because it will disturb the child, and we need to finish it in a very short time. Always we need to apply the Telshodu or modeling technique before starting an X-ray procedure, and we can do it in a multiple visits. The first visit can be a Telshodu or a modeling, and we can do the procedure, I mean the taking of X-ray in the second visit, because they are very apprehensive. Always dampen the film to avoid the taste, because it has a very different taste. Child might not appreciate the taste, so we need to dampen it to avoid that taste. And holding devices always use for post-it, because the child will not able to follow the instructions given by the dentist, how to hold, where to hold, because it's very difficult for the child. So always keep holding devices for the posterior teeth. So what are the film surveys? So film survey, it is like a combination of x-rays in order to get a proper diagnosis. Okay, so what happens in 3 to 5 years, that is when we have extensive caries or deep caries, what we are going to do is 2 posterior bite wing. For no apparent abnormalities, we can take 2 posterior bite wings using a size 0 film. When we have extensive caries, we go for 4 film survey. Also in case of deep caries, also 4 film survey. When in case of 6 to 7, where more teeth are there, so we need to go for 8 film survey. When there is extensive deep caries, we have to include additional periapical radiograph. In 8 to 9 years, we need to go for 12 film survey, and 10 to 12 years we need to think of 16 film survey or 12 film survey, depending upon the size. So this is how it is: 4 film survey, 8 film survey, 12 film survey, and 18 film survey. So what exactly is these 4 film? That is 4 film survey is maxillary and mandibular, anterior occlusal, and 2 posterior bite wing radiograph. So this is 4 film survey where we have maxillary and mandibular, anterior occlusal, and two posterior bite wing. Okay, two posterior bite wing and anterior maxillary and mandibular, two occlusal radiographs. This is 4 film survey, which is used for 3 to 5 years basically. So what is 8 film survey? 8 film survey, you can see 8 films where we have maxillary and mandibular anterior occlusal, then right and left maxillary posterior occlusal, right and left maxillary posterior occlusal, and right and left mandibular posterior periapicals and two posterior bite wings. You can see 8 radiographs where it includes maxillary and mandibular anterior occlusal, right and left maxillary posterior occlusal, right and left mandibular posterior periapical and two posterior bite wing. Where regarding the 12 film survey, it is having two primary molar to premolar periapical radiograph, 4 canine periapical radiograph, then 2 incisor periapical radiograph and 2 posterior bite wing. Whereas a 16 film survey, 12 film survey plus 4 permanent molar radiographs. So that was about the film survey. It is very commonly asked question. You need to write which all radiographs are involved in 4, 8, 12 and 16 film surveys respectively. Now we have the bite wing radiographs, that is periapical films are used to record the coronal portion of both maxillary and mandibular teeth in one image. Okay, you can see this maxillary and mandibular teeth in one image, which is basically used to identifying the interdental caries. So size 1 film is used for children and bigger 2 film is used in adult. And also we can check the level of bone. Next question is the incisor liability. It is a difference between the incisors of primary and permanent teeth, because the permanent teeth are bigger in size, primary teeth is lesser. So the permanent teeth has to come in position of smaller teeth, so it needs a bigger space. So there is a liability of space. So how do the arches, maxillary and mandibular arches, gain that space? That is the incisor liability. So the liability of space which is required for the permanent incisors to get accommodated in position of primary incisors, which is actually very smaller than the permanent teeth. So that is the size of permanent is greater than the deciduous counterparts, hence they need more space for proper alignment. So this difference in space required is known as liability. So in maxilla it is 7.6, mandible is 6 mm. So it is compensated by increased intercanine distance is increased by 3 to 4 mm and interdental spacing, and there is more of a labial eruption of incisors. In deciduous teeth it is more upright position, but in permanent teeth it is more labially erupting. That's how they overcome this liability. So that was all about the first part. That was a very short session. So there are many sessions coming up. So I'll come up with the next part in Pedodontic or Pediatric dentistry question paper discussion. Thank you. Hello everyone, welcome back to another session in dentistry and more. We are continuing our question paper discussion on pediatric dentistry, and we are into the second part of mini sessions. And this session also we are having very important questions lined up, so we'll be checking one by one. The first question was in the chapter growth and development, and it's a very commonly asked essay question: the development of occlusion from the gum path to the mixed dentition state and its clinical relevance. And as we all know, the eruption begins at 6 months of age, and there will be spaced dentition. The usual spacing between the teeth in deciduous dentition is known as primate space or physiological space. Some will be like non-spaced dentition. So if the physiological space is not present, there will be definitely crowding. in the permanent dentition. And we have the terminal planes, that is future molar relations in deciduous dentition as distal step, then the flush terminal plane and the medial step. So in future the medial step will become class 1 or class 3 depending upon the movement of mandibular teeth. Ideally it will fall into class 1, whereas flush terminal plane, it will result in end-on relation or end-to-end relation, and the distal step will result in class 2. And anterior teeth relationship, there can be overbite, edge to edge bite, or overjet, and canine relationship and arch dimensions. Whereas mixed dentition period, we have first transition period, inter-transition period, and second transitions period. And all we know the broadband phenomena, where the ugly declining state, when the canines are getting erupted, it pushes the lateral incisor, it in turn pushes the central incisor, and once the eruption of canine is complete, the labial displacement, the distal displacement of these central incisors will be normal and the teeth will be in an aligned phase. That is a transient state of malocclusion, because this canine will pushes the roots of lateral incisor, thereby it transfers the force into the central incisor root. So there will be divergence and there will be a diastema, temporary diastema present. But once the tooth erupts, it will be okay. So the next question is growth and development and the theories of growth and development. So you already studied all these theories in your ortho textbook. So the same theory you need to write it again. So growth, by definition, it's a dynamic process with stable patterns of changes resulting in increase in physical change of mass during the course of development. So many scientists given definition Stewart as development increase in mass, increase in size by profit. Moyer says quantity aspect. Todd says growth referred to increase in size, whereas development is increase in complexity. Moyer says naturally occurring unidirectional changes in life of an individual from its existence as a single cell to its elaboration as a multifunctional unit. So we know theories of growth, there are lots of theories. The most commonly we see in genetic theory, sutural theory, cartilaginous theory, von Limburg's theory, functional matrix theory, Enlow's expanding with theory. All we studied in ortho, not explaining one by one because you already studied all these theories. Just for example, functional matrix theory claims that origin, form, position, growth, and maintenance of all skeletal tissues and organs are always secondary, compensatory, and necessary response to chronologically and morphologically prior events or process that occurs in specifically related non-functional skeletal tissue. Okay, so it has skeletal unit, functional matrices. Again, it is divided into microskeletal and macroskeletal, capsular and periosteal. So that is most important theory, functional matrix. You already know it. Next, we have the terminal plane relationship. Mention the classification of terminal plane relationship. We already seen this. That is mesial step, distal step, and flush terminal plane, and how it is becoming in class 1, class 2, class 3, and end-on relation in the future permanent teeth. So next question is growth spurts define and add a brief note on significance. So we all know growth does not take place in a uniform manner at all times. There is a sudden spike in growth at certain age groups. that is just before birth, 1 year after birth. For mixed dentition time, the boys growth curve will be in an exponential phase at around 8 to 11 years, and girls for 7 to 9, and even for adolescents exponential growth seen 14 to 16 year for boys and 11 to 13 year for girls. So that is known as growth spurt, the sudden exponential accelerated growth compared to the other time period. So it is the best time for interceptive orthodontics. That is the most important things. We can remodel the growth. We can make changes in the bone growth. The orthodontic treatment is done earlier in girls as their growth spurt is early. And the earlier the onset of puberty, the smaller the adult. And girls mature earlier but also finish their growth sooner. That leads to difference in the adult size of men and women. And regarding the malocclusion, which requires surgical correction, should only be undertaken after the growth spurt is completed, because if any correction is done before the growth spurt, there will be chances of change in the relapse of the already done corrections. So always this surgical correction should be done only after the growth spurt completion. And class 3 tendency with mandibular prognathism should be treated before prepubertal growth spurt. Class 2, class 3 malocclusion should be treated during the growth spurt. Arch expansion can be done also during the growth spurt. Also, it always helps the expansion, because we can use the potential of growth spurt. If the jaw growth has to be accelerated, it has to be done before the adolescent growth spurt in girls. And next question is chronology of eruption of teeth and how chronologically the teeth erupts. We know first tooth erupts the central incisor, that is the lower central incisor, then the lateral incisor lower, then comes upper central, then upper lateral, then comes the lower canine, the first molar, then comes the lower canine, then comes the upper canine, then comes first molar. Before the cuspid there is upper first molar. You just see the order. This is given in months. Similarly, in the permanent teeth also, we know the first tooth erupts is the first molar, and we also having lower central incisor erupting in the same period. Then the lateral incisor, same time there will be upper central incisor. So you can just go through this table. That is chronology of eruption of teeth. Next question, write 4 characteristic clinical features of primary dentition. We can write many characteristic features of primary dentition. It can be related to enamel, dentine, pulp, root, the crown length, the crown shape, the color of enamel, the translucency of enamel. So everything, you have so many things to write in primary dentition and permanent dentition difference. The few are pulp cavities are larger in primary, enamel and dentine are thinner, enamel bulge at cervical ridge rather than taper gradually. Crown of primary teeth are more bulbous, often having labial and buccal singular. Now the most important short note, that is a leeway space of Nance. So what is leeway space of Nance? You need to draw this picture. That is a mesiodistal width of permanent canine and premolar. Okay, so you can see this is the 2 premolars and canine. This is a permanent teeth, and here we have canine and 2 deciduous molars. So this excess space, this small excess space. Okay, so we need to see the difference between these 3 teeth, that is the deciduous, canine and molars, with respect to its successors, that is canine and premolars, 2 premolars. So that is a difference in mesiodistal width of permanent canine and premolars with that of canine and molars. So always there is a difference, that is 1.8 mm in maxilla, that is 0.9 on the left side and similarly on the right side, and a large distance is present in the mandible because molars, lower molars are very wider mesiodistally. So that is why this is very larger, 3.4 mm in mandible, that is 1.7 on one side, whereas it is just 1.8, that is 0.9 on one side. The difference is not as large as seen in mandible. This excess space is called as E space. This is mentioned by Nance, so it is known as leeway space of Nance. So what are natal and neonatal teeth? So natal teeth which are present at birth, neonatal, that teeth erupts during the first 30 days. So natal teeth are encountered more often than neonatal in the ratio of 3:1, and it is more seen in females. Baby girls, teeth affected are lower primary central incisor, then maxillary incisor, then mandibular canine molars, and the least reported one are maxillary canine and molars. Etiology could be or any of these or all of these multi-system syndromes or any genetic abnormalities, trauma, hormonal stimulation, or superficial position of developing tooth germ. And there is a classification for these teeth: class 1, class 2, class 3 and class 4. Shell-shaped crown poorly fixed to the alveolus by gingival tissue, that is class 1, and there is no root. In class 2, solid crown and little or no root. Class 3, eruption of the incisal margin of crown through gingival tissue. Class 4, edema of gingival tissue with an unerupted but palpable tooth. So we can take radiograph to determine the amount of root development. Then gingival inflammation around the erupted teeth is controlled by chlorhexidine gluconate. This is all about management. So sharp incisal ridges scan laceration of ventral surface of tongue, which is known as Radiographic disease, or neonatal sublingual traumatic ulceration. So selective grinding is advisable. It may cause difficulty in breastfeeding and leave the tooth in place. Explain the parents the desirability of the tooth, which is important for the growth. So unless and until it creates so much a problem, we don't need to extract it. Now we have the primate space, that is also known as anthropoid and simian space, which is present between the lateral incisor and canine on the upper teeth and between the canine and first molar on the lower teeth. That is the space present mesial to the maxillary canine and distal to the mandibular canine. So in upper it is 1.7 millimeter and it is in lower it is 1.5 millimeter. It helps in early mesial shift, and leeway space of Nance helps in late mesial shift. So physiological space is a natural space between all the teeth, but primate space is particularly which is present mesial to canine on upper and distal to canine on lower. The leeway space of Nance is the difference between the canine and molars, deciduous canine and molars with respect to its successors, that is the canine and permanent premolars. So what are the self-correcting occlusion anomalies? We have so many anomalies. That is retrognathic mandible, it will be ready by as growth cessation happens by 17-18 years. Anterior open bed will be okay by the eruption of teeth, and posterior teeth, infantile solar will be okay. All are self-correcting occlusion anomaly. And there is anterior deep bite, it will be automatically corrected. Flesh terminal planes will be corrected. Space dentition will be corrected. Primate space, ugly duckling stage, all will be corrected once the permanent teeth erupts. So ugly duckling state we already discussed during 8 to 11 years. What happens is when the eruption of canine starts, it impinges on the roots of lateral incisor. So this lateral incisor in turn impinges on the roots of central incisor mesially. So what happens is the crown moves towards the distal side. So both the crown of central incisor moves towards the distal side. So there is a gap present in between the teeth. It looks like midline diastema, and the child feels ugly. But what happens after a few I mean after the 1 or 2 years, once the canine erupts completely into the oral cavity, the force transmitted to root now transmitted to crown. So this distally pushed tooth will be pushed medially from either side and it will be aligned completely. So it is a metaphor of ugly duckling, where the duckling was not looking good at when it was just born. After a few years, when it is completely grown, it is very beautiful swan. It became a beautiful swan. So it is a metaphor for the temporary looking ugly of 8 to 11-year uh, kids, where they feel like they are very ugly because of this presence of midline diastema. But it will be easily corrected automatically within 2 to 3 years, just like how the ugly duckling became a beautiful swan. So this is a difference in primary and permanent dentition. We know primary is lighter in color, this is darker. Duration 6 to 5.5 years. This is 6 years starting, and smaller in dimension. This is very larger. Mesodistal more than cervicocclusal. This is cervicocclusal more than mesodistal. Narrow occlusal table in primary, wide table in permanent. Enamel 1 mm thick. Enamel is thicker, that is 2 to 3 mm. Contact areas is more on gingival, but it is on occlusal. Mamelons are absent in primary but present in permanent. First molar always smaller than second molar in primary, but it is opposite in permanent dentition. So features of primary dentition according to Bomi, that is, it divided dentition into spaced dentition and non-spaced dentition. Spaced dentition, the spaces will be utilized for the adjustment of the permanent successes, which are larger than the deciduous one. So naturally there should be space in the deciduous dentition, otherwise there will be crowding in the future teeth. That is the primate space or anthropoid in simian space. That is, we already seen mesial to maxillary canine and distal to mandibular canine, which helps in early mesial shift. Whereas physiological spacing is present all over the teeth. That is 4 mm in maxilla and 3 mm in mandible. If there is no space, there will be crowding. This physiological space is the space present between all the deciduous teeth. But this primate is particularly mesial to maxillary canine and distal to mandibular canine. And importance of chronology of tooth eruption, that is the disturbance of normal sequence and ages of eruption are one of the contributing factors in development of malocclusion. It should be erupted and new tooth should be in position of the deciduous tooth in exactly at its chronological time. Otherwise there will be crowding, there will be labial eruption or lingual eruption. So it will result in malocclusion. So, and also to avoid the damage to the permanent tooth bed, and this age predilection of unknown patients in archaeological and forensics, all can be done by knowing the chronology of tooth eruption and maturity assessment or assessing the growth. All can be done by understanding chronology of tooth eruption. Teething is nothing but the problem the babies face when the teeth erupts into the oral cavity. Mostly it will associate with pain, inflammation, malaise, disturbed sleep, facial flushing, drooling, bowel upset, loss of appetite. So we can manage it by teething rings or sugar-free teething rice, cucumber peel can be given. If pain is there, analgesics or antipyretics can be given. Topical anesthesia will give some soothing effect. So that was all about this session. So we have many sessions coming up. So next sessions also will be dealing some very important questions in pediatric dentistry. So thank you. Hello everyone, welcome back to the question paper discussion of pediatric dentistry. We are into the part 3 of the mini sessions. So in this session, we'll be looking into the behavior management techniques in Pedodontics. It's a very vast chapter and many questions will be asked from this chapter. So the first question we have is the classify behavior of children, describe behavior management techniques employed in dental office, and the tail end is add a brief note on tell show do. So this last part can be any question. It can be desensitization, it can be home, it can be aversive conditioning. So it can be any question, but this is the common structure of behavior management question, that is a definition or classification, then describe all the techniques. It could be psychological, physical, and pharmacological, and then write a brief note on any one of those techniques. So we'll start with the classification of behavior that is given by Lampshire in 1970. The first one is cooperative, where the child is physically and emotionally very relaxed and is very cooperative throughout the procedure. Whereas the second one is tense cooperative. The child is tensed at the same time is cooperative. Then outwardly apprehensive. Actually, these type of kids avoids treatment initially. Usually hides behind the mother, avoid looking or talking to the dentist, but eventually they accept the treatment. Then we have fearful. They requires considerable support so as to overcome the fears of dental treatment. Then the stubborn people, they passively resist treatment by using techniques that have been successful in other situations. Hypermotive is a child who is acutely agitated. They do screaming, kicking, all those tricks to avoid the treatment. And we may have handicapped physically, mentally, and emotionally challenged people and emotionally immature kids. Next classification was given by Bingham. Category 1, emotionally compromised child. Category 2, shy and introvert. Category 3, frightened. Category 4, child who is adverse to authority. And we have Frankel classification. The Frankel is given as definitely negative, negative, positive, and definitely positive. In definitely negative, as the name suggests, they refuse treatment, cries forcefully, and they are very negative, uncontrollable, and defiant behavior. Whereas negative is they are reluctant to accept treatment and they displays evidence of slight negativism, and positive means they accept treatment. Definitely positive is unique behavior. They are pleasant, they accept treatment without much problems. Then we have another classification, that is Wright's classification. They are cooperative, lacking cooperative, potentially cooperative. Under that we have uncontrolled, defiant, timid, tense, weaning behavior, and stoic. Now let's see what are the types of fears in dental situation for children. So fear we can classify as general fear, or also we have dental fear. So fear is nothing but an unpleasant emotional state consisting of psychological and psychophysiological response to a real external threat or danger. It can be alertness, tension, and mobilization of the alarmed reaction. Or it can be also defined as a painful feeling of impending danger, evil, or trouble. Or in simple words, we can define fear as a reaction to a non-danger, whereas anxiety is to an unknown danger. There is a difference between fear and anxiety. So this question is about type of fear in dental situation for children. So dental fear, it can be fear of pain or its anticipation, fear of betrayal, fear of loss of control, fear of the unknown, fear of intrusion. So fear of pain or anticipation, it is like actual or misinterpreted pain or the anticipation of the pain. Unfortunately, discomfort and sometimes pain can still be a feature of dental treatment today, no matter how careful we are about trying to ensure about adequate analgesia. So, the research evidence suggests that uh, the trust of the dentist is a very important factor in dental fear. And fear of unknown or fear of is like in anyone's eyes, a visit to a dentist may be classified as a potentially threatening situation. And fear of intrusion is like most, if not all, the dental procedures are invasive. So, intrusion involves impinging on patient's personal space into a bodily cavity, the mouth. Impinging on a patient's personal space is something that is taken for granted by professionals. So they perceive this as a part of their caring role, even if the patients dislike the procedure intensely. So some children find this invasion of personal space very threatening. So that is fear of intrusion. And a fear of loss of control. The children are used to being cared for or controlled by parents. So they have an innate sense though of the boundary that defines the social from personal control. So letting a 4-year-old child choose which tooth to polish first gives them an appropriate degree of control. So that loss of control is a problem for the kids, because a 10-year-old may request that easy treatment is completed at a particular appointment because they have examinations afterwards or they are not feeling well, thus offering control over the noxious stimulus. They have the control. So ultimately, or the overtly offering children the opportunity to ask questions enhances their control over the information gained, thus offering decisional control. So this fear of loss of control is a problem for the child. Now we have the same question. What are the methods to reduce dental fear and anxiety in children? Add a note on the first dental visit of child. So I have already explained the definition of fear. So different types of fear corresponding to age. We have many types of fear in different age groups: 0 to 2, 2 to 4, 4 to 7, 8 to 10, 11 to 13. Like in 0 to 2, strangers, loud noises, strange objects. 2 to 4, being alone, darkness, animals. So it goes on like that with respect to various age groups. And various behavior management strategies. We can do primary, secondary, tertiary, and pharmacological management. On primary, we have safe, controlled environment, sense of control to the child, pre-appointment approaches. In secondary, that is behavior treatment, communications, behavior modification, parent in the operatory field, distractions. Tertiary level, we have desensitization, modeling, tell-show-do technique. And pharmacological, we have many techniques: nitrous oxide, oral sedation, rectal sedation, parenteral, aversive technique, and GA. So what are the common procedures carried out during the first visit? That is a history taking, social, dental, and medical history. Then the extraoral, intraoral, and after that radiographs, and explain aims of the treatment to the parents. And we do only simple procedures at the first visit. That is, if there is emergency at present, and treat for pain. And we'll do prophylaxis just exclusively on the incisors and maybe topical fluorides. So now we have so I was talking about the first visit procedures for a fearful child. Now we have dental fear and anxiety. So anxiety, as I explained before, it is a state of apprehension to a unknown danger, whereas the dental fear is all those emotional state is or a reaction to a non-danger. Okay, that is the difference, fear and anxiety. Now we are into the most important section of this chapter, that is the classification of behavior management techniques. You will get Definitely one question. It could be a long essay, short essay, or short note from this section in Pedodontics. So we have basically three categories in behavior management technique, that is psychological, physical, and pharmacological. Psychological, we have pre-appointment behavior modification, communication, use of second language, tertiary technique, dental love care, desensitization, contingency management, visual imagery, modeling, behavior shaping, assimilation and copying, hypnosis. And physical approach, we have home, physical restraints. Pharmacological, we have pre-medication, conscious sedation, and general anesthesia. So in psychological approach, the first thing is pre-appointment behavior modification, that is the contact with child's parent before the first dental visit. It increases likelihood of a successful dental treatment. So that is very important, pre-appointment behavior modification. Second one is a communication by involving a child in a conversation, which relaxes the youngster, and we can have two ways of communication, that is verbal and non-verbal. So basically it enhances the effectiveness of other communicative management techniques, that is a non-verbal one, and it gains patient attention and compliance and motivates the patient. So the verbal communication, it should be at the level of child, that is effective vocabulary should be used. Communication with children aged 2 to 7 years should be based on the animism, like giving life to an inanimate object, which involves giving life, like names to dental instruments, like hand pieces is like a whistling Charlie. And the important aspect of communication is getting the child to respond to dentist's commands. Two things must be remembered, that is the command may take some time to sink in and be implied with, and the second thing is the command should be within the ability of child. Okay, so it should be within the ability of child and it takes some time. So that was about communication. And we have audiovisual modeling, that is using video cassettes. Types of model can be used, can be siblings, parents. It is best recommended in same age patients. It can be a descriptive praise, that is a praise emphasizing on specific cooperative behavior, and it can be a signaling. So signaling allows the patient to communicate with the dental team during any phase of treatment by means of previously established signal with specific meanings. The patient, by raising a hand or a finger, can communicate their wish to stop the treatment, for rest breaks, or to notify dentist of an unpleasant feeling. They can give signals. Whereas a descriptive praise, like the praise emphasize specific operative behavior, like thank you for sitting still, or like you are doing a great job keeping your hands in your lap, rather than a generalized praise like good job. We need to be very descriptive because we are dealing with child, so we need to be very elaborate, like you are doing a great job keeping your hands in your lap, rather than saying just good job. Use of second language or euphemisms, like is very important, like for example, addressing the child at his or her level of comprehension. This does not suggest the use of baby talk, but rather employing words that have meaning for the child. This means not speaking to an 8-year-old as if he or she were 3 year and vice versa. Does a 3-year-old understand what it means to evacuate or vacuum the mouth, or rubber dam clamp? So we need to use these substitute, like dental terminology like air as wind, anesthetic as sleepy medicine, burr as a pencil or brush, caries as a brown spot, explorer as tooth counter, matrix as fence for filling, x-ray as camera, radiograph as picture, handpiece as a whistling train. So we need to use all these euphemisms, so to get the child within our control, so we can start our procedure. Now we have tell show to technique that will be deal in future slides, and we have desensitization. Desensitization, it was developed by James and later popularized by Wolf. It means to take away one's sensitivity to a type of behavior. So it is a therapeutic technique that pairs an anxiety evolving stimulus with response to inhibitory to anxiety, like relaxation as inhibitory of anxiety, visual imagery of anxiety provoking stimuli with the patient maintaining profound muscle relaxation. So the technique calls for a hierarchy of fear stimuli, whereby the patient conquers fear or anxiety towards low anxiety or moderate anxiety stimuli before approaching the more dramatic stimuli. So the technique usually involves teaching the patient to induce a state of deep muscle relaxation, and while the patient is in relaxation state, tell him to imagine scenes that are relevant to his fears. So these imaginary scenes are presented to the patient in a graduated fashion so that scenes provoking minimal anxiety are initially described and gradually more stressful situations are presented. So in this way, we can manage the patient. So next one is modeling, that is also we are dealing in detail. Then behavior shaping, that is dental assistant or dentist teaching the child to behave. Contingency management, it is like we have positive reinforcement, negative reinforcement, timeout or punishment, or it is like a presentation of a positive reinforcer or withdrawal of a negative reinforcer. Okay, so positive reinforcer, like which increases the frequency of desired behavior, because we are giving a present or giving a toy, which increases the a chance of patient to become very cooperative. Negative reinforcer, it is like withdrawal increases the frequency of behavior. We are keeping the parent out of the clinic. We are telling the patient that we are keeping the parent out of the clinic if you're not being cooperative. So it is the withdrawal increases the chance of the patient being cooperative. Okay, so these reinforcers can be material, it can be a social, it can be an activity, so it can be anything. So we can manage the patient by giving a positive or negative reinforcer. So what exactly is omission or timeout? So it is a withdrawal of the pleasant stimulus to reinforce good behavior. So asking the mother to stay out of the dental operatory makes the child cooperative. And punishment is like home, hand over mouth exercise, voice control, something like that. Distraction. Distraction is a new method of behavior management in which the patient is distracted from the sound or the sight of dental treatment, thereby reducing the anxiety. By telling the stories of fairy tales, using slow instrumental music, or it is to relax the patient and reduce anxiety during treatment. We can switch on the TV and let the patient, the child watches his favorite cartoons. Can be an audio distraction, can be an audio visual distraction. So that is about distraction. After that we have parental absence or presence, and we have retraining. Retraining is a technique which is similar to behavior shaping, designed to fabricate positive values and to replace the negative behavior. So it is like avoidance, that is avoid extensive pulp therapy with pulp capping. De-emphasize and substitution, that is substitute high speed hand pieces with spoon excavator. And it can be distraction, that is distract child with stories, activities and audiovisual aids, that is retraining. It is almost like behavior shaping. Then we have voice control, that is sudden and firm commands that are used to get the child's attention and stop the child from his current activity. So firm commands can be a very powerful tool for the patient management. Now we have physical approach, that is home, that is hand over mouth technique, and protective stabilization. Hand over mouth technique will be dealing in detail, that is keeping a folded napkin over child's mouth gently and behavioral expectations calmly explained. Used only with parental consent. Now let's see what is aversive conditioning. So aversive conditioning, it is an extension of overall behavior guidance designed to facilitate the goals of communication, cooperation, and delivery of quality oral health care. It includes many techniques, that is voice control, hand over mouth exercise, and physical restraint. All can be combinedly done. Now we have the tell, show, do technique. So tell, show, do is a cornerstone of behavior management, which was given by Adelson in 1959. So the classic model for communicating with child and favorably conditioning them to dental experience is, first we need to tell, then we need to show and do. So the verbal explanation of procedures in phrases appropriate to the developmental level of the child. In telling, explaining to the child exactly what you are going to do. After that, uh, the telling part is over. Then we need to show the thing which was explained earlier, that is demonstrating visual, auditory, olfactory or tactile aspects of the procedure, and the noise of the running handpiece, the material which will be used. So anything we should demonstrate it. So after that, without deviating from the explanation and demonstration, the dentist proceeds directly to perform the previewed operation. So that is first telling, then showing, after that doing. So there are many alternatives for this tell, show, do technique, that is ask, tell, and ask, tell, play, and do. All these are the modifications. Ask, tell, ask is explaining the procedures through demonstration in a non-threatening language appropriate to the cognitive level of the patient, and again inquiring if the patient understands about the treatment. So that is ask, tell, and ask. So that was about tell, show, do technique. Then we have home, that is already explained, hand over mouth exercise, introduced by Jordan in 1920. Indicated in 3 to 6 year old child who exhibits defiance and hysterical behavior, and they can understand the simple verbal command, and they displays uncontrolled behavior, but it is contraindicated in less than 3 years and handicapped and physically and mentally challenged students, I mean the kids. Modeling and observational learning, it involves allowing a patient to observe one or more individuals who demonstrate a positive behavior in a particular situation. Therefore, the patient will frequently enact the model's behavior. So it can be done on siblings. The well-behaved sibling can be kept nearby, and he is very cooperative, so the patient also will try to model him. So it can be a poster, it can be film models or audiovisual aids. Now we are into the Electra and Oedipus complex. It is part of the psychology. It is seen during phalanxate. The key event in this stage, according to Sigmund Freud, is the attraction of the child to the parent of opposite sex, with envy and fear of the same sex parent. In boys, this situation is called Oedipus complex. Boys experience castration anxiety, which comes from fear of punishment. In this process of identifying with father, the boy not only takes up his behavioral pattern but also his ideas of right and wrong. In girls, this type of attraction is called Electra complex. Conscious sedation, a minimally depressed level of consciousness that retains the patient's ability to independently and continuously maintain an airway and respond appropriately to physical stimulation or verbal command, and that is produced by a pharmacological or non-pharmacological method or a combination of both. So we have many agents for achieving conscious sedation. It can be opioids, morphine, fentanyl, and benzodiazepines like diazepam, midazolam, lorazepam, barbiturates, chloral hydrate, propofol, ketamine and nitrous oxide. Most commonly used is nitrous oxide for conscious sedation. So what exactly is diffusion hypoxia? So diffusion hypoxia is a decrease in PO2 usually observed as a patient is emerging from an inhalational nitrous oxide anesthesia. So the rapid outpouring of insoluble nitrous oxide can displace the alveolar oxygen. It displaces alveolar oxygen, which results in hypoxia. So all patients should receive supplemental oxygen at the end of the anesthetic procedure and during the immediate recovery period. So immediate recovery period, we should always make sure that we have sufficient supplemental oxygen for the patient, because nitrous oxide always try to this insoluble one which can replace the alveolar oxygen. So there will be hypoxia. So the nitrous oxide conscious sedation, there are many steps. First, we need to review the medical history and other medication of the patient. Then say the vital signs, BP, pulse, respiration and saturation level. Select proper size of the nasal hood. Turn on oxygen and assess the patient with placement of the nasal hood over the nose. Then patient's tidal volume to identify proper flow rate. Then start the nitrous oxide at 10 to 20% concentration. Then every 1 to 2 minutes it increases by 5%. And once the ideal signs and symptoms are observed, begin treatment. Upon completion of treatment, turn off nitrous oxide. Then start administering 100% oxygen for at least 3 to 5 minutes to avoid diffusion hypoxia. Then we need to document the procedure, including flow rate, amount of time, amount of 100% delivered upon completion of procedure, and patient's response. So it is indicated in fearful or anxious child to accept dental treatment. Contraindication, mainly kids with cold, tonsillitis or nasal blockade, or pre-cooperative children, and also for ladies with first trimester of pregnancy. So the signs are open or closed eyes, tears, trance-like expressions, speakings, laughing, abducted feet, open or closed hands. So that was about conscious sedation. That is again a essay question. Now we are into the theories of child psychology. We have basically two categories of theories. One is psychodynamic theories. Then we have theories of learning and development of behavior. So in psychodynamic theories, we have psychosocial theory, then cognitive theory, and psychosocial theory. So the famous psychosexual theory was given by Sigmund Freud, and cognitive theory by Jean Piaget, psychosocial theory by Erik Erikson, then classical conditioning by Ivan Pavlov, operant conditioning by Skinner, hierarchy of needs by Abraham Maslow, social learning theory by Albert. So psychic triad, it was given by Freud in 1923. That is tripartite structural model of ego, id and superego. So the behavior is influenced by the biological drives, that is id, then the social rules, that is superego, and meditating thought processes, that is ego. So it was a classical psychoanalytical theory of psychosexual theory. So he compared the human mind to an iceberg. That is, small part above the water is conscious mind, and we have three components. It is the most primitive part of personality. It is the basic structure of personality, which serves as a reservoir of instinct. Okay, whereas superego, that part of personality that is internalized representation of the values and morals of society as taught to the child by parents and others. It is essentially an individual conscience, and it judges whether the action is right or wrong. Whereas ego, it is a part of self that is concerned with overall functioning and organization of personality through its capacity to test reality and utilization of ego defense mechanism. So ego is concerned with a state in which an adequate expression of it can occur within the constraints of reality and demands and restriction of superego. For example, hunger must wait until food is given. The ego spans all three topographical dimensions of conscious, preconscious, and unconscious state. So the ego is the executive organ of the psyche and control motility, perception, contact with reality, and through the mechanism of defense available to it, the delay and modulation of drive expression. So Freud believed that ego substitutes the reality principle for the pleasure principle. So that was the complex theory of psychoanalytical theory, or this theory where we have the three components: id, ego, and superego. So we already discussed this one, and now we have this psychosexual developmental stage, that is oral stage is up to 1.5 years. Anal stage we have 1.5 to 3 years, urethral 3 to 4, phallic 4 to 5 years, latency 5 to puberty, and genital puberty onwards. Okay, now we have the psychosocial theory, or theory of developmental tasks, given by Erikson. So he explains the stages of psychosocial development as like a ladder, where it starts from the bottom of ladder is stressed versus mistressed. At the apex it is integrity versus despair. So in infants it is like increasing complexity, that is stress versus mistrust, and in older adult it is like integrity versus despair. So each stage is characterized by different psychological crisis the person of that age group is undergoing, which is to be resolved before he moves into the next level. That is what this theory is all about, that is stages of psychosocial development. That is infancy, we have 0 to 1, where we have the problem of trust versus mistrust. This stage identifies with the development of separation anxiety with the child, dental treatment to be provided with a parent present, preferably holding the child. Whereas toddler 1 to 2 years, that is autonomy versus doubt. That is, child moves away from the mother but still retreats to her in case of threatening situation. So hence the parental presence is essential. Child gets pleasure by doing tasks by himself. So the dentist must give a feeling that the treatment is his choice. Whereas stage 3, that is early childhood, age 2 to 6 years, initiative versus guilt. That is preschoolers. This stage identifies with the development of separation anxiety with the child. Dental treatment to be provided with a parent present, preferably. So initiative versus guilt. For most children, first dental visit occurs in this stage. Going to the dentist is a new and challenging adventure. So exploratory visit is a good way to start the dental experience. Coping with the anxiety can develop a great sense of independence and accomplishment. Poorly managed visit contributes to guilt and failure. Whereas stage 4 is elementary and middle school, that is industry versus inferiority. Here the children are aimed at learning new skills and goals. The key behavior is to guide in setting intermediate goals and outline the child how to achieve these goals and positively reinforcing it. Children are not motivated by abstract concepts but rather status and acceptance in peer group, that is by emphasizing on how the teeth looks rather than occlusion, by comparing with peer groups, that is 6 to 12 years, where they are very conscious about their teeth. And in 12 to 18 years, there is stage 5 adolescent state, that is crisis between identity and role confusion. Parental authority is being rejected. Approval of peer group is more important for these age groups. So commonly orthodontic treatment is carried out in this stage because the peer group influence is high. So there may be loss of status for being one of the few in the group for not receiving the treatment, because they are very conscious. They are very much like being liked by the peer group, and they are very influenced by the peer suggestions rather than the parental one. So they seek orthodontic treatment or aesthetic treatments mostly by the peer influence. So it's important to make them realize that the treatment is done for them and not to them. Whereas 19 to 40 years, that is intimacy versus isolation. External appearance become important, therefore more focus on orthodontic and aesthetic treatment. In 40 to 65 years, that is creativity versus stagnation. And lastly, late adulthood, that is age 65 to death, that is integrity versus despair. So that is all about the theories of child psychology. We have many other theories I have not included, that is theory of cognitive development. They are not very important, given by Jean Piaget. Then we have other theories like hierarchy of needs and the theory of operant conditioning. So all are not very important, but mostly these two essays will be asked, that is psychosocial, psychosocial developmental and the psychoanalytical theory, and ego and superego is also very important. So I'll come up with the fourth part of periodontic question paper discussion now. Next session. Thank you. Hello everyone. Welcome back to the continuation of pediatric dentistry question papers. We are into the fourth part, and today we have preventive periodontics. It is basically pit and fissure sealants and fluorides. So fluorides is a very big chapter, but it's very easy because you already studied in your part 1, that is under the subject public health dentistry, where you have studied in detail about fluorides, the history of fluorides, systemic fluorides, topical fluorides, the mechanism of caries prevention, the defluoridation techniques, and the fluoride toxicity. So the same is repeating in Periodontics, because Periodontics, it's a compilation of all other subjects like Orthodontics, oral surgery, and preventive side, on the diagnostic part. So we have the first question, that is systemic fluoride delivery in prevention of dental caries, and discuss the professionally applied fluoride techniques. Basically, fluorides can be applied in two ways. One is systemic approach and another one is topical approach. And it can be self-applied and professional applied. Self-applied means the person can use by himself or herself without any much expertise, just like the toothbrush and using the fluoride toothpaste, the fluoride mouth rinse. Whereas professionally applied, where the expertise is required, just like topical fluoridation techniques, sodium fluoride, stannous fluoride, or APF gel. So anyway, we'll start with systemic fluoridation. We have water fluoridation, that is community water fluoridation, and it can be school water fluoridation. Community water fluoridation, the parts per million is just 1 ppm, because we are supplying it 24/7. Whereas school water fluoridation, milk fluoridation, and salt fluoridation, it all needs more ppm, that is 4 to 5 ppm compared to the community water fluoridation, that is 1 ppm, because the students consume less amount of water from schools, or the children consume less amount of milk and salt. So in order to get the protective effect of fluoride, that is 1 ppm in net, we need to provide 4 to 5 ppm with respect to milk, salt, and school water fluoridation, where we are not getting a 24/7 fluoride delivery. Whereas community water fluoridation, we are getting 24/7. So we need just 1 ppm to get the maximum caries protection, because 1 ppm is the optimal level where we get maximum caries protection. Above that we get fluorosis, below that we won't get the protection against caries. And it can also be applied to fluoride drops, that the theory can be applied, caries prevention, fluoride tablets, and fluoride lozenges. Now let's see, I'm not going in detail about the milk, salt, drops, tablets and fluoride lozenges. We have already studied the same in public health dentistry in detail. What are the basic requirements for water fluoridation, then milk, salt. Now let's see the professionally applied fluorides, that is sodium fluoride, stannous fluoride and APF. Sodium fluoride is commonly known as Knudsen's technique. We are applying into 4 applications, 1 week interval, that is in the particular age group 3, 7, 11 and 13, because they are corresponding with eruption of new teeth, new permanent teeth and deciduous teeth, molars and central incisor. So we need to apply all these fluorides in recently erupted teeth, because the recently erupted tooth is not completely mineralized. So the complete mineralization will be done after 2 to 3 years of eruption, because they need to capture the elements and ions from saliva and receive. So it takes 2 to 3 years. So we need to protect the teeth during the post eruptive 2 to 3 years. So that time we need to apply fluoride. So sodium fluoride is 16 application will be there, because in each age we are going to apply 4 applications at 1 week interval, that is 2% of sodium fluoride. It is neutral in pH 9200 ppm, because we are providing it topically, so we need to have a very high ppm, because the systemic fluoridation can be applied in many ways, but it is the patient or the child is consuming it. But here we are applying it topically, where the tooth has been maturated. Where the systemic fluoridation, we are utilizing the potential of mineralization. It directly enters to the crystal, but in topical it is creating the top layer demineralization, and thereby a byproduct calcium fluoride is formed, thereby it supplies the fluoride. So the mechanism is different in systemic and topical. Next we have stannous fluoride. It is another material is using. Stannous fluoride was proposed by Moeller, so it is known as Moeller solution. It is 8% of stannous fluoride and it is applied twice here. APF is different one. It is known as Woodward solution, that is 1.23% of APF, and most of the products we apply is 4 minutes, until 4 minutes. So we are applying it for 4 minutes, so it reaches the saturation point. So beyond 4 minutes there is no point of applying it, because it becomes very saturated. After that it won't enter into the enamel. So that is the third product as APF. Next we have a short essay regarding dental fluorosis and defluoridation technique. So dental fluorosis, we need to write about Dean's fluorosis index and its 6 category. We know it is normal, very mild, moderate, severe, questionable. So that category and its appearance we need to write. After that, defluoridation techniques. We have many techniques. One is adsorption, then ion exchange technique, precipitation, and electrochemical and reverse osmosis. Adsorption is by using activated, that is, it gets adsorbed to the surface. Adsorption and absorption is different. Adsorption on the surface, okay, absorption within. So adsorption can be done using bone char, brick piece column, mud pot, natural adsorbent, activated alumina. Ion exchange, we can use anion and cation exchange, that like carbon 1, carbon 2. Defluoridation by precipitation, that is the most common one, using alum and lime, that it gets precipitated, combines with the fluoride, and fluoride will be precipitated due to the chemical action. Then we have reverse osmosis by electrolysis, and Nalgonda technique, which is the most popular one. Nalgonda is actually placed in the Andhra state, that is exactly it is placed in the Telangana, where this technique, mixing of alum and lime by the locals, they have invented this technique. After that it is commercialized by NEERI, that is National Environmental Engineering Research Institute in Nagpur. Nalgonda technique, it was invented by the people of Nalgonda, which is in Telangana state. not in Nagpur. So people get confused. I mean, the students get confused when asking Viva. They directly jump and say Nalgonda is placed in Nagpur. It is not. Now we have spit and fissure sealants, its indication, contraindication, rationale. It is very detailed, studied in conservative dentistry, in public health dentistry. So it is a very common question. It's very easy question. We need to write in under different subheadings. Like one is classification. We have many classification based on chemical structure, generation, filler content, color, curing, and chemical structure, MMA, Tech DMA, BIS GMA. So all those things. Then first generation, second generation, third, fourth. Third is visible light, fourth is fluoride, second is self-cure, first is ultraviolet, unfilled one, filled one, clear, tinted, colored, autopolymerizing or light cure polymerization. So indication, we know pit and fissure is a preventive method. It is done on a tooth which might where the caries might start, and it is likely to start mostly deep tooth with deep pits and fissures like molars and premolars. So we just remove the little bit of pits and fissure, and we apply the pit and fissure sealants. But mostly it is a non-invasive procedure. We just apply it on the pits and fissures. When we are making it invasive procedure, it is known as preventive resin restoration. What are the indications of pit and fissure sealant? That is newly erupted tooth, especially primary molars and permanent molars and bicuspid with complete recession of pericoronal operculum and open grooves and fissures where the food gets stuck and bacteria will act, it will create acid and caries might occur. So the rationale is simple. We are sealing pit and fissures, so food won't get stuck, bacteria won't come, acid won't get produced, and there won't be any caries. So contraindication, if there is any caries, we can't do because it is completely a preventive procedure. We are not making any cavity. We are just applying after the basic cleaning, and we are applying it using a conditioner, or we might use a etchant, but we are not making any removal of tooth structure. So if any type of caries, we should go for restoration. Pit and fissure sealant is not a restoration. So technique is first isolation, then preparation of tooth. That it can be used aluminum oxide. It can be treated with sherry of fumes and water. Then we will go for acid etching, then rinsing, then bonding agent, then application of sealant, curing and revaluation, and recall and revaluation. Next question is diet counseling and its role in the prevention of dental caries. So diet is one of the key factor of causing dental caries. That is, it is a multifactorial disease. Diet is one factor, then time is another factor, host factors is there, bacteria is there. But if we are removing one factor out of these four factors, we can prevent dental caries. Diet counseling is very much vital, because diet can be a host factor, it can be a agent factor because it is coming from outside. So it is like a factor which is there in the host and agent. So we can do a direct counseling where the role of patient is passive and the decisions are made by the counselor, and non-directive counseling where the counselor role is merely to aid the patient in clarifying and understanding situation and to provide guidance so that the patient can make his or her own final decision so as to type of action that should be taken. So this non-directive counseling approach is recommended for diet counseling. So a prerequisite for successful nutrition counseling is a realistic and honest statement that the patient, not the counselor, bears a responsibility for making changes in food selection and eating habit. So first we need to gather information, then evaluate, then develop a plan, then seek active participation of patient's family, then follow-up. So follow-up is very much vital because the patient has a tendency to change the habit, but there will be relapse. So we need to have a frequent visit to make it a habit. So what are the topical fluoride agents? We already discussed sodium fluoride, stannous fluoride, APF, amine fluoride. All are topically applied agents. APF we already discussed. Now we have very important question, that is caries vaccine. We know dental caries remains one of the most widespread disease, but it cannot be prevented by a vaccine because it is a multifactorial disease. A single factor disease can be prevented by vaccine, just like polio, mumps, measles, or those single microorganism which causes it can be prevented. But since caries is a multifactorial disease, there are so many factors are involved, we cannot prevent everything by a single vaccine because there are host factors, there are agent factors, many factors are. We can only prevent the microorganisms or its growth, its population multiplication. So that way we can one of the factor can be prevented, but not dental caries, because there is diet is there, host factors are there. It cannot be prevented or it cannot be modified by a vaccine. Vaccine is always applicable to a disease where it is caused by a single organism. So caries vaccine, there should be a strong association is existing between colonization and mutant streptococci, and we are focusing, as I said, only on streptococci. Okay, so we are thinking of its protein. So somewhere we need to interrupt the process of this formation, dental pellicle formation, or by inferring proteins or its adhesion. So somewhere we are going to interrupt this attachment or its multiplication, that is bacteria I'm talking about, streptococcus, and its pathogenicity of streptococci occurs through the adhesion of this to hydroxyapatite. So that way we are trying to prevent the adhesion. So these glucose polymers provide scaffolding for the aggregation of mutants and other oral streptococci through interaction with bacterial cell associated glucan binding proteins. So these are the targets, vaccine targets, such as adenosine antigen 1 and 2, glucosyl transferase, glucan binding proteins. All these can be kept as a target. So active immunization can be done through oral, intranasal, tonsillar, using rectal minor salivary glands. So all these routes can be used. Now we have fluoride dentifrice. Before that, we need to understand what is dentifrice, its composition. Sodium fluoride and stannous fluoride are using as a fluoride delivery agent. Okay, so toothpaste has many components. It has abrasive, it has humectant, it has a binder, and one of the component is fluoride delivery agent. So that part we are modifying. Some of the toothpaste doesn't have a fluoride delivering agent. So here we are using amine fluoride dentifrices or monofluorophosphate. So this becomes a fluoride delivery agent. So these are the key component in the toothpaste which delivers fluoride. Okay, so most of the herbal toothpaste doesn't have fluorides. So age recommendation for fluoride dentifrices: below 4 years not recommended, 4 to 6 once daily, 6 to 10 twice daily, and above 10 thrice daily with fluoride paste. So fluoride varnish, developed by Schmidt in Europe, 1964. Increasing time of contact is there because it is almost like sticky. So after prophylaxis, we can apply varnish. Application is done first on the lower arch, then upper, using a small brush, and just like other topical fluoride, we are leaving it for 4 minutes. So Durafate and Fluor Protector is there. These are the two commonly available fluoride varnishes. And microfilled resins can be used as a composite for a small cavities. It can be used. Preventive resin restoration, there are three types: type A, type B, type C. It is restoration. It is completely different from pit and fissure sealant because pit and fissure is a preventive technique. This preventive resin restoration, the name itself is a little confusing because we are saying preventive and we are making a restoration. Restoration means something we are going to restore, something restore which is already lost. So tooth material is lost, so we are restoring it. So we have type A, type B, type C based on the depth of cavity. So type A is very minimal, type B is a little more deeper, type C is a deeper one, where we are filling resin, not like amalgam. So little conservative approach cavity we can make, unlike amalgam, which requires a lot of tooth destruction. Whereas pit and fissure sealant is just a sealant material applied on the normal tooth without any cavity cutting. Okay. So cool water fluoridation we already discussed in detail, why we are applying 4 to 5 ppm and instead of 1 ppm, and what are the results. So type of fissures, we know what are the type of fissures: V, U, I, IK, inverted Y, all are important in pit and fissure sealants. So that was a part 4. We were finishing it so fast because you guys already studied it in part 1 and you are going to study it in your other subjects. So fluoride is a very important topic because you get many questions, but it's not very tough chapter because you know most of the concepts because we studied in detail about its history, systemic, topical, various topical methods, various products, about defluoridation and fluoride toxicity. So next we have pediatric orthodontics, which will be dealt in next session. So we haven't discussed about toxicity. That slide is missing here. So anyway, toxicity, we have acute toxicity and chronic toxicity. Chronic toxicity is nothing but fluorosis. It can be a dental fluorosis and skeletal fluorosis, that is getting accumulated fluoride getting accumulated over a very longer period. Slowly we are getting fluoride, and if it is during the mineralization state of hard tissues, there will be fluorosis. It can be as a dental or skeletal. Dental happens between 1 to 3 ppm, more than 3 ppm. Skeletal also can happen. Whereas acute means it is a sudden heavy dose of fluoride is getting into our systemic circulation. It can be by accidental, or a person tried to by in an act of suicide, and certainly lethal dose is 32 to 64. That is around 5 gram. If one person consumes, he might die. So we can manage it by providing some milk or other material because it is a binder, or we can induce vomiting, or other measures we can take, taking patient to hospital. So that was about the toxicity. So next I'll be taking the part 5 where the orthodontic parts are coming. So even though I did not concentrate much on the topic fluorides, this is very important. Many questions will be asked from this session. Essays will be there, short essays will be there, and short notes. Many questions are there. You need to refer the Soben Beta textbook, or even Nigilmava is fine. So I'll come up with the part 5 of pediatric question paper discussion. Thank you. Come back to the continuation of pediatric dentistry question papers discussion, and we are into the 5th part of many sessions, and today's session is dealing with orthodontics, that is pediatric orthodontics. And the first question regarding the classification of oral habits, then it is explaining the deleterious effects of mouth breathing and diagnostic tools and management. Okay, so And, this question doesn't include the definition of habits. It is starting with classification, but definition, as you all know, Voucher defined habit as a tendency toward an act or an act that has become a repeated performance, relatively fixed, consistent, easy to perform, and almost automatic. So that is the definition of habit. So classification, we have many classification, that is James as one as useful and harmful habits. Useful habits means they are for the normal function, such as correcting the tongue position and agglutination, and harmful habits which is acting against the teeth and dental arches, like mouth breathing and tongue thrusting. And we have another classification given by Finn: compulsive and non-compulsive. Compulsive acquired as a fixation in the child to the extent that he retreats to the practice whenever his security is threatened, whereas non-compulsive is they undergo continuing behavior modification which permit them to release certain undesirable habit patterns and form new ones which are socially accepted. Okay, compulsive is based on the security threatening, and this is which is socially accepted ones. And primary habits are normal habits, whereas the secondary habits due to the supplemental problem like large tongue which causes a tongue thrusting habit. Meaningful and empty habits. Meaningful are with a deep-rooted psychological problem. Empty are meaningless that can be treated easily by a dentist using a reminder therapy. And we have another classification: normal and abnormal. Normal are normal according to the age group. Abnormal are habits which pursued after their physiological period of cessation. For example, if the child is having a persistent thumb sucking even after three and a half years, it is called abnormal habits. Until that period, it is normal. Now we have physiologic and pathologic. Physiological are normal, which is required for normal functioning, that is nasal respiration, sucking during infancy, whereas pathological, due to the pathological reasons such as adenoids and nasal septal defects, that may lead to mouth breathing. Retained and cultivated habits are retained are carried over from childhood into adulthood. Cultivated, those cultivated during the socio-active life of an individual. So what are the deleterious effects of mouth breathing? So we know mouth breathing which can cause adenoid faces, that is long face, lips will be held apart, there will be short upper lip, chin is receded and typical pigeon face, nose is tipped superiorly, the bridge of nose will be flat and long narrow face. All are the problems of mouth breathing. So how do we diagnose mouth breathing? There are many tests, many diagnostic methods. The first one is observing the patient. So these mouth breathers, the lips will be apart, whereas the nasal breathers, lips will be always touching because they are breathing through the nasal. But in mouth breathers, they have to open the mouth, so lips will be apart. And asking the patient to take a deep breath through nose. Mouth breathers, there will not be any change in shape or size of external nares, that is, there will be remains same during the inhalation and exhalation, whereas nasal breathers, they demonstrate good control of alar muscles. So mouth breathers, there is no change in shape or size of external nares because they are breathing through the mouth. But nasal breathers, there will be change in the alar muscles. That size might it will change because of the flow of air through the nasal cavity. Next one is a mirror test. It is also called as fog test. So we need to take a two surface mirror on the patient's upper lip. So if the air condenses on the upper side of the mirror, so the mirror is two-sided, okay. So if the air condenses on the upper side, the patient is a nasal breather, but if it does on the opposite side, that is on the lower side, is a mouth breather, because air is passing through the lower side. Now we have the water holding test, that is, patient is asked to hold the mouth full of water. Mouth breathers cannot retain the water for a long time because their breathing is interrupted. Now we have the butterfly test. We need to take a few fibers of cotton and place it just below the nasal opening. So what happens is, on exhalation, if the fibers of the cotton flutter downwards, the patient is a nasal breather, but if fibers flutter upward, is a mouth breather. Now we have the rhinometry, that is, a total airflow through the nose and mouth can be quantified using this plethysmography, and we can make out which kind of respiration is a person is having. And the last technique is cephalometrics. We can calculate the amount of nasopharyngeal space using the cephalometric analysis. So what would be the treatment for this? So the main aspect of management of a mouth breathing patient is to treat and eliminate the underlying cause or pathology which created the habit, and after that, symptomatic treatment. So other procedures and appliances that can be used are deep breathing exercise, lip exercise, and oral screen. See, if it is due to the adenoids, that has to be corrected, or if any other problems, the cause which is creating this habit should be corrected. Otherwise, the symptom, if we are doing just symptomatic treatment, there will be continuous problem, there will be relapse. Now we have the question of space maintenance. So classify space maintenance, then discuss the sequelae of premature loss of deciduous teeth and describe the management of a 5-year-old child. This is a very commonly asked question. The year 5-year-old might become 6-year-old, 7-year-old, 8-year-old, just to confuse you. So always expect a question like this. 5-year-old child who requires extraction of mandibular right second deciduous molar. Okay, so you need to be very cautious while writing the answer. It can be a first deciduous molar, second deciduous molar. So the scenario is different. So you need to be very cautious because it may easily get changed. Mandibular right and second, first and second deciduous molar. You need to read the question very properly and write. So classification of space maintenance. So Hitchcock classified it as removable or fixed or semi-fixed, with and without bands, functional and non-functional, active or passive, and combination. Raymond's classified removable, complete, individual tooth. Hendrickson classified it as fixed space and removable space. In fixed space, class 1, class 2, where non-functional, functional in class 1, cantilever in class 2. Now just let's learn the sequelae of maxillary deciduous first molar. So what happens when the maxillary deciduous first molar is absent? So this question will be there. It can be maxillary deciduous first molar, or maxillary deciduous second molar, or even mandibular questions will be there regarding the first and second deciduous molar. So while writing, you need to be very careful because you might end up writing the wrong answer. So what happens when maxillary deciduous first molar is lost? So this deciduous cuspid, okay, shifts distally in the first year only, if at all, if it is shifting, and the first permanent molar and second deciduous molar shift mesially, okay, with the amount depending on the duration of absence and age at loss, at what age the tooth is getting lost, or what is the duration of absence. So depending upon that, first permanent molar and second deciduous molar. Okay, so that will shift mesially, whereas a cuspid it shifts distally, and an erupting first bicuspid, that is a premolar, is guided along the mesial surface of mesially migrating second deciduous molar, and it eventually lying close to the lateral incisor. So this is what happens when maxillary deciduous first molar is lost. Whereas maxillary deciduous second molar is lost, what happens is second bicuspid is generally impacted and permanent molar shift mesially. The cuspid and first deciduous molar shift distally. As the first bicuspid generally has an eruption timing advantage over the second bicuspid, it will erupt earlier into the site maintained by the first deciduous molar because that is a successor, and often with a distal drift. So the resultant lack of space between the permanent molar and first bicuspid causes impaction of second bicuspid. So you need to visualize this when I am talking. So it is not very confusing. So what happens is, the first thing is the second bicuspid will be impacted, permanent molar shift to mesial side, towards mesially, and canine and first deciduous molar shift distally, and this distal drift will be there by the first deciduous molar. Next we have the sequelae of loss of mandibular deciduous molar. So the effect of mandibular extraction tend to be similar for all three situations, that is loss of primary first molar, second molar, or both, unlike the maxillary. So timing differentials between the canine first premolar and second premolar and the mandible appears to account most of the similarity among groups. So in case of loss of first primary mandibular molar, the permanent first molar and deciduous second molar tips forward, and in case of loss of second primary mandibular molars, the permanent molar tip forward. In case of loss of first and second primary mandibular molars, the permanent molar will tip forward and primary canine will tip distally, leading to impaction of bicuspids, and it will result in midline shift. Now we are into the space maintainer categories. The first one is the distal shoe space maintainer. It is very commonly asked question: when, how, where this space maintainer is kept. From this picture it is very easy. There will be a stainless steel crown. From the distal side there will be a bar which is pointing towards the mesial side of erupting permanent first molar, and it will guide the eruption pathway. So what are the indications? When the second deciduous molars lost prior to the eruption of first permanent molar. Okay, so that time we need to keep this distal shoe space maintainer. We need to maintain the space for first permanent molar. Okay, so what are the indications of distal shoe space maintainer? As I mentioned, when the deciduous second molar, that is E, are lost prior to the eruption of first permanent molar. See, permanent molar will be erupting distal to the second deciduous molar, that is distal to E. This E will be replaced by the premolars. Okay, this D and E will be replaced by the premolars. So what happens is, this E supposed to be exfoliated by the age of 10, 11, but it is extracted due to many reasons. It could be caries or any other reason. It is lost before the eruption of first permanent molar, that is before the age of 6 or 7 years, because that age where the permanent first molar erupts. So if it extracted at the age of 5, what happens is, this molar will come to the space of E. Okay, so what happens is, when this premolar comes to this space, it will get impacted. There will not be any space for this premolars. Okay, so this space has to be maintained for the eruption of premolars. because this D and E will be replaced by first premolar and second premolar, and this molar should be at this level. If this space is not maintained, what happens is this molar will eventually be here and there will not be any space for premolars. So that is how distal surface of second primary molar provides a guide for unerupted first permanent molar. So when the second primary molar, this one is not here, removed prior to the eruption of first permanent molar, the intraalveolar appearance provides greater control of path of eruption of the unerupted tooth and prevents undesirable mesial migration. So this will not go to mesial side if it is kept here. So it will act as a guiding plane. That is the distal shoe space maintainer. You need to understand the concept. So design using first primary molar as abutment. This is the first primary molar. The second primary molar is missing. So there will be a steel band is adapted, and from this steel band there will be a horizontal bar and an intraalveolar extension which is directing towards the mesial side of this erupting permanent first molar. Okay, so this is how it is created to this prepared for stainless steel crown, and on the band it is fitted and impression is made, band is removed and place impression, and the stone model is prepared, and all those things, usual preparation steps. So indication, I told unilateral loss of primary first molar before the eruption of first permanent molar, and unilateral loss of first or second primary molar after the eruption of first permanent molar, or bilateral loss of first primary molar before the eruption of permanent incisors and first permanent molar, or bilateral loss of second primary molar after the eruption of first permanent molar. So in any scenario we can use this. But contraindication, an occlusion that is extremely crowded or already exhibits marked space loss, high dental caries activity, replacement of primary anterior teeth or replacement of primary second molar in transitional dentition with permanent molar not erupted, we cannot use this. So I already explained this. This is a wire and band loop. This is a crib. Crib is a portion of the wire spanning edendular space. This is the edendular space, and crib is a wire spanning through the edendular space, and there is a loop portion of the wire contacting the abutment tooth. This is where the contacting abutment tooth and band which encircles the abutment. Now define and classify space maintainer. Describe about fixed space maintainer for bilateral loss of deciduous molars. So according to Bausch, it is fixed or removable appliances designed to preserve the space created by the premature loss of primary tooth or a group of teeth. Okay, so classification we have learned earlier. So bilateral loss we have on the lower teeth, that is lingual arch space maintainer. This is a lingual arch space maintainer where it is taken abutment from both molars, and there is a band, there is a wire arch which is running from one molar to the another molar through the lingual side of remaining teeth. So it is a bilateral, non-functional, it could be passive or active mandibular fixed appliance. It is fixed, and it is the most effective appliance for space maintenance and minor tooth movements in the lower arch. And the design. So this arch wire, this is the arch wire. This arch wire should contact the erupted permanent incisor. This is a permanent incisor. It should contact permanent incisors at the cingulum. So this is the cingulum part. And arch wire should be located 2 mm below the gingival margin. Then or edentulous ridge in the posterior region to prevent distortion and the process of mastication, and should be located 1 to 2 mm lingual to the posterior teeth, permitting satisfactory eruption of the bicuspid. Here should not interfere with the premolar eruption. And the arch wire should meet the band at mesiobuccal cusp and at the same time place the soldered joint in the middle third of the band to avoid occlusal interference. It should not come to the incisal or occlusal side, it should be at the middle third of the band to avoid occlusal interference. So there are modifications for this lingual arch space maintainer, that is Hodge lingual arch with a U-loop for space regaining, and removable 1 and omega bends in canine region to prevent interference. And the one which is applied in the maxillary arch is a Nance palatal arch. It is again bilateral, non-functional, passive, fixed appliance that does not contact the anterior teeth. Okay, it is coming in contact with the palate, unlike the mandibular Nance, the lingual arch space maintainer. It is contacting the permanent anterior teeth where it is not contacting. Instead of that, it has an anterior palate acrylic button that contacts the palatal tissue. This is the acrylic button which provides a resistance to the anterior movement of posterior teeth in a horizontal direction. Okay. So the archwire extends anteriorly without touching against the surface of primary molars. See, archwire is going like this without touching primary molars, as a successor bicuspid usually are broader buccolingually. Okay, it should not come here, it should not go like this because it will interrupt this premolar eruption and the wire could deflect them if it is kept here. So at the rugae area, small U-shaped bend is incorporated, which is approximately 1 to 2 mm away from the soft tissue, and the bend will enhance the retention. And this acrylic button is 0.5 inch in diameter, is placed usually on the descending portion of the palatal wall, 1 to 2 mm below the incisive papillae. This is the incisive papillae. Now we have next question, that is interceptive orthodontics, and enlist various interceptive orthodontic problems in children. Discuss the management of an 8-year-old boy with retained maxillary primary, central incisor and lingual eruption of permanent central incisor. So that's what I was saying, this 8-year-old boy, 6-year-old girl, that question will be there. So make sure the concepts are very clear. So the Interceptive Orthodontics, American Association of Orthodontists, defined it as a phase of science and art of orthodontics employed to recognize and eliminate the potential irregularities and malpositions the developing dentofacial complex. So we have many procedures like serial extraction, space regaining, correction of crossbite, oral habit elimination, muscle exercise, interception of developing skeletal malocclusion, removal of soft tissue or bony barrier. So next question is define oral habits, discuss the clinical feature and management of thumb sucking. Okay, habits I already mentioned the definition. Thumb sucking, the clinical features: digits appears reddened, exceptionally clear, chapped and a short fingernail, that is clean dishpan thumb, and lips will be the position at a rest or during swallowing should be observed. There will be a short hypertonic upper lip, lower lip will be hyperactive and this leads to proclination of upper anterior teeth. Convex profile will be having for the child and higher incidence of middle ear infection, enlarged tonsils. So regarding the intraoral examination, the type of malocclusion produced by digital sucking is dependent on a number of variables like position of the digit, associated orofacial muscle contractions, mandibular positions during sucking, facial skeletal pattern, frequency, duration and intensity of habit. So how do we manage it? Firstly, feed the child whenever he or she is hungry. Secondly, feed the child in a natural way. Importance of breastfeeding is primarily psychological and secondarily nutritive. Thirdly, never let the habit to be started. The practice must be discontinued at its inception. And use of a dummy or pacifier, encouraging the baby to suck a dummy instead of his thumb. In psychological therapy, nagging, scolding or frightening the child should be avoided since this could cause negativism. Beta hypothesis or Dunlop's hypothesis says that if a subject can be forced to concentrate on the performance of an act at the time he practices it. He could learn to stop performing the act. Forced purposeful repetition of a habit eventually associates with unpleasant reactions and the habit is abandoned. So this child should be asked to sit in front of a mirror and asked to observe himself as he indulges in habit. In chemical treatment, bitter and sour chemicals can be applied like quinine, pepper, castor oil, etc. All these things can be applied, but it is found to be not very useful. And in mechanical therapy or remainder therapy like spleens, adhesive tapes, oral screen, quad helix, removable or fixed palatal clip, thumb guard, all can be used. And regarding the current strategies, there are thumb home concept, use of hand puppets, increasing the arm length of night suit, all can be used. Now we have a question, that is space maintainers discuss the management of an 8-year-old girl with untreatable bilateral mandibular primary molar. So all are explained previously. You can use a lingual arch appliance. Mouth breathing is already explained. Classification is obstructive, habitual and anatomical. Now we have crossbite and its explanation about inclined plane, that is Catalan's plane. According to Graeber, crossbite is a condition where one or more teeth may be abnormally malposed buccally or lingually or labially with reference to the opposing teeth. It's very simple. Crossbite, you know. So what are the types of crossbite? Dentoalveolar. This is often manifested as a single tooth crossbite and usually occurs due to the over-retained deciduous teeth. Whereas functional one, the presence of occlusal prematurities, which deflects the mandible into a more forward path of closure. So this type crossbite results from the functional shift of mandible. It's commonly seen in pseudo class 3 and it can be easily treated by eliminating this occlusal prematurity. It is a functional one. Whereas skeletal anterior crossbite, where it is due to the skeletal discrepancy of maxilla or mandible. So whole segment is affected instead of one or two teeth. So it can be because of maxillary retrognathism or mandibular prognathism. Okay, this type of crossbite is best intercepted by the growth modification using myofunctional or orthopedic appliances. So it is indicated used only in those cases where the crossbite is due to palatally placed maxillary incisor. So it is constructed 45-degree angulation on the lower anterior teeth by acrylic or cast metal. Now we have preventive orthodontics and discuss the various methods of serial extraction. So Graeber defined as action taken to preserve the integrity of what appears to be normal occlusion at a specified time, or it is the prevention of potential interference with occlusal development. So serial extraction, it is initiated in the early mixed dentition and it is a process of extracting certain deciduous teeth and later specific permanent teeth in an orderly sequence and a predetermined pattern to guide the erupting permanent teeth into a more favorable position. Okay, so we are guiding the teeth in a favorable position by creating a sequence of extraction of teeth. So it is done in cases which show signs of persistent irregularities of teeth due to the insufficient space in the arch. Okay, so there are most commonly three methods. This Dual's method, Tweets and Nance method. Dual's is CD4, first is deciduous canine, then the deciduous first molar, after that first premolar. This is almost same, Tweets and Nance. That is first molar, then comes first premolar, after that canine. So definition we already seen. The indications and procedures. Indications, we know premature loss of deciduous teeth, arch length deficiency, absence of physiological spacing, lingual eruption of lateral incisor, mesial rift or buccal segment, gingival recession, abnormal or asymmetric primary canine root resorption, crowded maxillary mandibular incisor. So ultimately, if there is lack of space or there is discrepancy in size and tooth, so all these can be indications for serial extraction.
So Tweed's method we already discussed, extraction of deciduous first molar by 8 year, then the first premolar followed by deciduous canine. Dual cis, first deciduous canine, then deciduous first molar after an year, followed by extraction of first premolar. So how do we manage the anterior crossbite? So if there is adequate space for the tooth in crossbite to be moved into its correct position, tooth can be guided with the help of a tongue blade. So it should be used an hour or two per day for 10 to 14 days. It is sufficient to deflect the lingually erupting tooth into a proper relationship. And it can also be intercepted by using a Catalan appliance and double cantilever spring with posterior a removable appliance. Now what is lip bumper? As you see here, you can see a lip bumper here. Lip bumper or lip plumber is a combined removable fixed appliance. It is modified vestibular screen that is used for muscular force application or for elimination. It can be used in both maxilla and mandible to shield the lips. So it is preventing the lips action on the teeth and these gum structures. So it is made up of thick stainless steel wire extending from one molar to this molar, and wire made is lie away from anterior teeth. The lip bumper is inserted into the round molar tubes. So you can see these tubes, an anterior portion of the wire from canine to canine. So lip bumper used in maxillary arch is known as Denholz appliance. So it is used in patients exhibiting lower lip habits such as lip sucking, and in patients exhibiting hyperactive mentalis muscle activity, that is causes flattening or crowding of the lower anteriors, distalization of first molar. So what are space regainers? It regain the space, that is Gerber space regainer and cantilever spring. Gerber space regainer is an orthodontic band or a crown selected for the tooth to be distalized. So this space regainer consists of U-shaped hollow tubing and a U-shaped rod that enters the tubing. The tube is soldered or welded on the mesial aspect of first molar to be moved distally. Whereas cantilever spring molar can be distalized to regain space by using removable appliances that incorporate simple finger springs. And anterior space regainer, it is like standard label tubes are mounted and an open coil spring passes through the central incisor tube. And also King's appliance, that is the edgewise bracket is spot welded to the buccal surface. You can see this one, buccal surface of the primary molar band, and the completed anchorage unit is cemented. Okay, a band with an ankulated buccal tube is cemented on the malposition molar, and a straight section of wire with an open coil spring is introduced into the buccal tube and ligated into the bracket. So Tweed's analysis, that is part of cephalometric analysis. We have Steiner's analysis and Down's analysis. Mostly expect this Tweed's analysis because it is a simple one. Down's and other one is a little complicated. Tweed's we have triangulation, that is FMA angle, IMP angle and FMI angle. All together it constitutes of a triangle that is 180 degree. So FMA angle is mandibular plane angle 25, IMP is 90, that is lower incisor angle. FMIA is angle between Frankfurt horizontal plane and lower incisor plane, that is 65 degree. Okay, so that is all about the orthodontic part of pedodontic questions. So we will come with the sixth session, that is we have Cariology and other things. So hope you understood this. It's the most confusing one is the distal shoe and the band and loop, lingual arch and other things. So I'll come up with the sixth part in my next session. Thank you.
Hello everyone, welcome back to the continuation of question paper discussion and pediatric dentistry. We are into the sixth part of our question paper sessions. So this session is about cariology, caries management and various caries detection tools. So the most commonly asked question
was about early childhood caries. Describe the stages of ACC and management and differentiate between nursing bottle caries and rampant caries. So let's see the definition of our early childhood caries. So it is the presence of one or more decade, it could be a non-cavitated or cavitated one, missing or filled tooth on any primary teeth in a child that is 71 months of age or younger. 71 means almost 6 years. If the child is under 3 years of age, that is children younger than 3 years of age, if any sign of smooth surface caries which is indicating of severe early childhood caries. This is childhood caries. Early childhood caries was talking about 71 months, almost 6 years or younger, but this is 3 years of age. That is known as severe ECC. From age 3 to 5, one or more cavity, these are the criteria. If it is age 3 to 5, one or more cavity, missing or filled surface in primary maxillary anterior teeth, or a decade, missing or filled score more than 4 in number for age 3, more than 5 in number for age 4, and more than 6 for age 5. That all constitute as severe ECC. Okay. So what could be the etiology? It is very simple one, that is poor oral hygiene, insufficient fluoride, and decay causing bacteria. Oral hygiene, as we all know, if oral hygiene is not there, it is directly linked to plaque accumulation, and over the plaque we will be having bacteria, and there will be production of acid and tooth demineralization, which is tooth decay. And fluoride, insufficient fluoride. Fluoride is naturally occurring mineral which is found to be preventing tooth decay. So these fluoride sources include toothpaste, mouth rinse, normal tap water, all can prevent dental caries to an extent. So if you don't have sufficient amount of fluoride, there will be chances of caries. And the presence of bacteria. That is, many bacteria work together to cause tooth decay, but certain bacteria play key role, like Streptococcus mutans, that is smooth surface caries, and Lactobacillus causes deep surface caries, deep caries. That was about etiology of early childhood caries. Now the stages of ECC, that is, it is starting as initial, reversible, then damaged caries stage, then deep lesion and traumatic stage. In initial stage, it is like chalky white discoloration along the gum line, and there will be plaque, and it is reversible. If you do proper oral hygiene and remineralizing agent, we can reverse it. The next step is, or next stage is, damaged caries stage. That is, this chalky white is becoming yellowish brown discoloration with cavity, and dentin is also involved. It could be asymptomatic or sensitive to cold. Whereas the next stage is more advanced, that is deep lesion, which is present on molars and incisors. It is involving pulp. It could be painful, sometimes asymptomatic, and last stage is traumatic. Tooth is already gone, the structure is gone. Fracture and minor trauma will lead to loss of crown structure, and maxillary incisors are non-vital. Pulpal involvement is there, pain may or may not be present. Next we have prevention. So how do we prevent ACC? So we have various methods. First one is using a chlorhexidine varnish, then do a proper dietary counseling. And early detection is a vital thing in prevention of ACC. When we have a detection or a screening before the age of 1, that will be very vital. We can give fluoride supplements, fluoride dentifrices, prenatal fluoride supplements, water fluoridation, and control of mother-infant infection with cariogenic bacteria. All can be applied as preventive strategies. So how do we manage it? So this is a basic flow chart of managing ECC. You can just pause it here and see what are the steps. So initial or recall visit, how do we include it, then how do we manage it. We have caries risk assessment, then clinical examination, caries charting, and self-management goals. So all are there. That disease management visit from 1 to 3 months, 3 to 6 months, and 6 to 12 months, all are there. So basic thing is we need to do caries risk assessment. We need to take radiographs. We can start with topical fluoride in the initial visit. So we need to have a good support from the patient also. So we need to explain caries process and causes of ECC. So proper communication is very important in management of ECC. So you can just draw this flow chart when you have the question of ECC management, not explaining it because it's all self-explanatory. So what is the difference between nursing caries and rampant caries? Very commonly asked question, and it's very easy one, but it is still a confusing one for many of the students. They write opposite answers for nursing caries and rampant caries. So the first thing you need to understand is nursing caries is a specific form of rampant caries, because rampant caries is a bigger one. So nursing caries is a type of rampant caries. Okay. So rampant caries, it is acute widespread caries with early pulpal involvement, which are usually immune to decay. So in which age group it is seen? Nursing caries seen in infants and toddlers and basically affects primary dentition, whereas rampant caries seen at all age, adolescents, and affects both primary and permanent dentition. Okay, so rampant caries is a bigger classification, and one of the type is nursing caries. So in nursing caries, mandibular incisors are not involved, but in rampant caries that is also affected. Etiology, nursing caries, basically it is bottle feeding before sleeping or applying pacifiers or prolonged breastfeeding. Whereas rampant caries, the etiology could be multifactorial, bottle factors, frequent snacking, excessive sticky, carbohydrate intake, decreased salivary flow, or genetic background. Now we have the same question being repeated. ECC, describe in detail about etiology and management. And next question, same question, but clinical features are there, and again management. Next we have question that is diet counseling and its role in prevention of dental caries. That is, diet plays a central role in development of dental caries because it is both same time host factor and agent factor. So it is clearly shown that relationship between frequent consumption of carbohydrates and caries activity. There is a strong evidence, there is a causal relationship between frequent snacking and caries activity. So if we can modify the diet factor, we can control the caries. So the local effects of diet on plaque metabolism and specifically on acid production are considered to be far more important for caries development than the systemic effect of tooth development and saliva components. So caries is basically depend on diet. So if we manage diet well, we can prevent majority of the caries rather than the other factors such as saliva and tooth development. So how do we conduct a counseling, dietary analysis? A vigorous and comprehensive program of dietary counseling is reserved for those few patients for which such is required, that is children with extremely high caries susceptibility, those with numerous caries lesions affecting both features and small surfaces, or children with history of caries who are beginning full banded orthodontic care. or children who for whatever reason are unable to maintain a relatively plague-free oral environment. So these are the basic people who should be getting dietary counseling. And when a comprehensive dietary consultation is to be accomplished, the parent is asked to keep a diary of the child's food intake for 5 days. Then it is evaluated with the parent to demonstrate all of the exposures to refined carbohydrate the child has received and to suggest the alternatives. So diary keeping is very must, and it should be with the parent. So most parents are surprised at the frequency and degree of the child's intake of fermentable carbohydrate. So these are the method, that is 24 hours diet recall, recalling the food and drinks consumed the last 24 hours. The advantage is it does not alter food intake pattern. It can be easily remembered, but the problem is we need to have a trained interviewer. There is chance of recall bias. The patient might not properly recollect what he or she had taken in the last 24 hours. It is not actually representative of the patient's routine dietary intake. It could be on a festival day, the patient might have taken more sweets or more other carbohydrate food, which is not, or which is contradicting its usual pattern. So next we can use a food frequency questionnaire. It is easy to administer, does not change the usual food intake, but again recall bias. It is not open-ended, it is a closed-ended. Open-ended means the patient or the child has liberty to explain in detail, but this is not open-ended, this is a closed-ended, so he has to choose from the options given, and there is high chance of measurement error. And next one we have the dietary assessment. Also we have diet history. So all can be used to check the or do the dietary analysis, and based on that we can do the dietary counseling. Now we have the most important short test, that is caries detection tool. So we have visual tactile, that is a conventional method, then radiography, caries detecting dyes, fiber optic trans illumination, electronic caries monitor. So what are the ideal requirements of caries diagnostic aids and various diagnostic aids? Okay, so clinical method, on we know how to do it using explorer or sharp probe. Smooth surface lesion normally develop close to the gingival margin and are often covered in plaque. And on the buccal and lingual surfaces, optimal assessment is a visual appearance. You can just see the visual appearance. And on the fissures and approximal surfaces, it's more difficult visually, and we use indirect methods. And white spot lesion can be seen when enamel has been cleaned and dried. Okay, so that is a basic clinical method. Then we have the radiographic methods, that is a wide wing projection is the most useful. X-ray for detecting caries. Using X-ray we can we can see the presence of caries at very early stages. Always use a paralleling technique, which increases the value of projection of detecting caries. So using size adult 2 size films for wide wing examination. So what are the dyes in caries detection? That is Procyon, calcium, brilliant blue, or are used for the enamel caries, dentin caries, basic xenon, methylene blue, and acid red. So modified dye preparation uses iodine. It measures the enamel porosity in incipient caries lesion, that is very beginning caries. So it's the white spot caries or white spot lesion. Caries is just started. And also use we can use potassium iodide. Diagnodent is an instrument by which we can detect caries, that is class 1, 5 and incisor lesion. Caries can be accurately measured. It is there will be visual examination and radiographs and transillumination aids is there. Intraoperative caries evaluation and helps in decision making to restore or not to restore. So excellent caries management tool measuring the effectiveness of non-surgical caries treatment, that is remineralizing strategies. Now we have ECM, that is electronic caries measurement. Sound dental hard tissues shows very high electrical resistance, and demineralized enamel has lower resistance. So we can easily make out from this principle. And 40 is fiber optic transillumination, uses light transmission through the tooth. So demineralized dental hard tissues scatter and absorb light more than the sound tissue. For enamel and dentine caries reduction on occlusal, proximal and smooth surface of anterior and posterior teeth, this can be used. So Dialex is one company or one fiber optic transillumination from the Cavo company. So what is anticipatory guidance? So it is a step-by-step program taught by the dentist or dental professional in an office to caregivers and is tailored to each specific child. So it is a time-intensive procedure that includes but is not limited to examination, prophylaxis, diet analysis, home care instruction, supplemental fluoride, both topical and systemic and general feeding instruction. Okay, so what are the instructions? Try to stop night feeding once the teeth erupts. Use methods other than feeding to calm a crying child. If a child needs a bottle to fall asleep, it should contain plain water. Breastfeeding should be encouraged with good oral hygiene. Discourage ad libitum breast or bottle feeding. And for infants who continue to feed on demand at night, parents should wipe the teeth clean after feeding. So what is the difference between caries susceptibility and caries activity? Caries activity is the increment of active lesions. It could be new or recurrent over a period of time. Okay, so it is a measure of speed of progression. So how fast it is getting progressed, that is activity. Whereas caries susceptibility is the inherent tendency of the host and target tissue to be affected by the caries process. That is the difference. Now we have Miller's acidogenic theory. That is, Miller was the first well-known scientist and investigator of dental caries, and according to him, dental leak is a chemoparasitic process. That is, chemical is produced by the parasite, that is a bacteria. So two-stage process. There is decalcification of enamel, which also results in destruction of dentin. The second stage, there is dissolution of softened residue of the enamel and dentin. So there is a production of acid by the bacteria, and which causes dissolution and destruction. Rampant caries, we already discussed rampant caries. All this were discussed. So we know how it is affecting in the stages, how it is stage 1, stage 2, stage 3, all were discussed. Now we have the Snyder test in 1951. It is measuring the ability of salivary microorganism to form organic acid from a carbohydrate medium. So we use a bromocresol green indicator which changes the color of the solution based on the pH. When pH is 5.4, it is green. When the pH is 3.8, it is yellow. So if the indicator dye is not there, that is bromocresol green is not there, we will not be able to understand the change of pH. But when we put the dye, the color of the solution will be changed so that it is easily visible and measurable. So when the color change happens within 24 hours, there is high caries activity, that is marked caries activity. Within 2 days, that is 1 to 2 day, moderate. 2 to 3 days, that is slight caries. If nothing happens, no color change happens after 72 hours or 3 days, the person's saliva is negatively caries active. Sugar substitutes are substitutes which can be used to manage the problem of carbohydrate, and the carbohydrate are the positive thing for caries, so we can manage it by using sugar substitute. It is classified as nutritive and non-nutritive. Nutritive, we have rapid sweetness, sucrose, fructose, dextrose, and non-nutritive with alcohol and high intensity artificial ones. Sugar alcohols, xylitol, maltitol, sorbitol. The xylitol and sorbitol are commonly present in chewing gums. And this high intensity ones are sucralose, aspartame, saccharin, neotame. Window of infectivity is the age or the period at which the child is having high amount of bacteria. So it is between 19 and 33 months, during which most children acquire the cariogenic organism. So mother was the most common source of transmission of bacteria to the child. So factors affecting window of infectivity is high maternal infection, high dietary sucrose level. So children should be immunized before the window of infectivity. Okay. So that was all about the part 6. It was basically about the cariology, the early childhood caries, its clinical features, etiology, management, and we have many short notes like window of infectivity, sugar substitute, Snyder test, rampant caries, Miller's theory, caries activity and caries susceptibility, and anticipatory guidance, and the diagnostic aids like 4T, ECM, Diagnoden, dyes, radiograph, and clinical methods, and regarding the dietary counseling and the difference between nursing caries and rampant caries. So I'll come up with a part 7 in my next session, that is about restorative dentistry. Thank you. Pediatric dentistry question papers. We are into the 7th part of sessions, and we are having 1 or 2 sessions remaining. So this session deals about restorative dentistry in pediatrics. So the most commonly asked question is the morphological variations between primary and permanent molars and their applications in class 2 cavity design of primary molars for amalgam restoration. So as we all know, class 1 restoration is not having much of the features, requirement features in the axial wall, pulpal wall, and the other remaining structures of the tooth. But class 2 design requires a lot of features in order to retain the restoration in position. So let's see what are those features. So before that, let's see what are the differences between deciduous and permanent teeth. So we all know deciduous teeth are small in size, crown is bulbous, crown is light in color, and there is a prominent cervical ridge, especially at the first deciduous molar, and it has got short trunk, that is the furcation is directly after the cervical line, and also it has got widely divergent root. Okay, it is to enclose the developing successor beneath it. And almost opposite features are present in permanent teeth. Now let's see what are the amalgam preparation requirements for class 2. So first thing is the depth, establishing depth using a pear-shaped burr. The preparation by penetrating the occlusal surface from the central fossa and extend towards the mesial side and terminate at the mesial lesion. Okay, so we can use a periodontal probe to check the depth of preparation. So for normal a plastic tooth, that is 1.25 to 1.5 millimeter from the cavo surface, depth should be there, and it should be measured at the mesial ridge area, whereas a natural tooth penetrate 0.25 mm into dentine. Whereas regarding the width, at the isthmus area, about 1/3 to 1/4 distance between cusp tips should be there, and isthmus width on the second primary molar is slightly greater than on the first primary molar. So that is the difference. Now extension into grooves. So grooves extended using this 330 burr and the high speed handpiece should maintain the depth, and tilt the burr towards the oblique ridge as you approach it to avoid undermining the ridge. Once the oblique ridge is approached, create a dovetail, but make sure that you do not undermine the oblique ridge. Next, extending the buccal groove approximately equal to the width of the burr and create a dovetail. Then extending mesially and create a dowtail, leaving only thin wall of enamel so as to protect the adjacent tooth from abrasion. And you can use a slow speed finish burr to smoothen the walls. So we can have a depth of 1.25 to 1.5 mm. Buccal and lingual walls should converge slightly towards occlusal direction. Distal wall should be vertical in minimal. In maximum model, it diverges slightly. The oblique ridge must not be undermined. Only thin wall of enamel should be left mesially. And all line angles should be rounded. Okay. So now how to prepare the proximal box. Using the same burr, insert the cavity against the wall of tooth structure and move the burr in a gingival direction and buccolingual with a pendulum motion. Okay, this will provide the slight convergence of the buccal and lingual walls towards the occlusal. And extend the proximal box gingivally to break contact with the adjacent tooth so that tip of an explorer can be passed through. So this buccal and lingual walls of proximal box extension will create a self-cleansing area, and this can be determined by the clearance of an explorer tip. And it is, if it is necessary, use a hatchet to plan the lingual and buccal walls of the proximal box, and axial wall follow the contour of tooth. Okay, and after that the depth of proximal box is approximately 2.5 to 3 mm depending on the clearance, and proximal box wall extends so as to explorer tip can pass through the embrasure, and this proximal box should be wider gingivally than occlusally for the retention, and width of the gingival seat is approximately 1 mm, and proximal box extend gingivally so that the tip of an explorer can pass through. Depth of the proximal box from the pulpo-axial line angle to the gingival seat approximately 1.25 to 1.5 mm. And we should round the axial pulpal line angle because it can create stress points if it's not properly rounded. And the sharp cavo surface angle in the buccal and lingual walls, a 90 degree is desirable, and there is a slight extension into the fissured mesial-buccal groove. The axial wall of the proximal box is at the same depth as the pulpal wall, that is 1 to 1.25 mm. The gingival wall on the minimum model is just at the level of gingiva. On the maximum, it is 0.5 mm below the gingiva. And the occlusal distal thing is, it is extending into grooves terminate the dowtail at central pit. The transverse ridge, which is not undermined, is left intact. Mesial wall at the transverse ridge is slightly undercut on the minimum model or vertical on the maximum. This isthmus is 1.25 to 1.5 mm wide. And preparation of the proximal box is already mentioned. So what are the common errors in proximal class 2? That is failure to extend occlusal outline, failure to follow the cuspal outline, too wide isthmus, great flare of proximal walls, great axiobuccal or axiolingual line angles, and failure to break the contacts, straight axial wall or deep gingival floor. These can be the common errors in proximal class 2 preparation. Next, we have a very important topic in pediatric restorative dentistry, that is stainless steel crown. First, we need to check about the classification regarding many classification. First, about trimming, that is untrimmed and pre-trimmed crown. Untrimmed are neither trimmed nor contoured and require a lot of adaptation, like Rocky Mountain crowns, whereas pre-trimmed crowns are straight, non-contoured sides, but are festooned to follow at line parallel to the gingival crest. They still require contouring and some trimming. That is, examples are Unitec and 3M. Whereas pre-contoured crowns, they are pre-contoured through a minimal amount of festooning and trimming. Unitec stainless steel crown, and 3M also has a pre-contoured crowns. Next classification regarding the composition, that is stainless steel, 18-8 austenitic stainless steel, nickel chromium. According to position, crown for posterior, crown for anterior, According to company, the Rocky Mountain Unitek Trium, Nussmile Crown and Iconal. According to the occlusal anatomy and Unitek and compact occlusal anatomy, Unitek West occlusal anatomy, Rocky Mountain, Omco. What are the indications of stainless steel crown? The first one is extensive caries or extensive decalcification, recurrent rampant caries after the pulp therapy in order to protect the tooth, or enamel defects such as amelogenesis imperfecta, hyperplasia. If there is a intermediate restoration or a fracture of primary incisors, severe bruxism, and if we need to have a prosthesis on abutment as a part of space maintenance, whereas it is contraindicated in primary molars which is about to exfoliate, primary molars with more than half the roots resorbed, teeth with mobility, teeth which are not restorable, patients with non-nickel allergy. So what are the various crowns available, and discuss about the strip crown. So already we seen the classification, and we have some anterior stainless steel crown, facial cut stainless steel crown, pre-veneered, bonded crown, strip crown, shell crowns. It's all for the primary anterior teeth. And this is pediatric strip crowns. There is no collars to cut off and there is no seams that split. It is very time saving, cost effective, simple to fit and trim, aesthetically very pleasing, clear, thin and smooth, which is perfect for photo curing. So there are anterior starter kit, primary starter kit and second primary starter kit, all are available in the market. So we just have to put it on the existing tooth so it looks very natural, and it's very easy to very easy job for the pediatric dentist. Now let's learn about the preventive resin restoration. So it is a restoration which is done by resin, okay, on a preventive mode. So we have three types of cavities here: type A, type B and type C, depending upon the depth. So in type A it is very minimal, type B it is little more deep, and type C more deep. So in type A we just apply on the enamel, whereas type B it involves dentine. So we have a base here because it involves dentine, and we keep a composite, and over the top we have fissure sealant. Type C we have base, then a posterior composite because there is more tooth loss here, so we need to have a good composite which has more strength, and over that we apply fissure sealant. So it is basically treatment of small caries lesions where caries is removed and restored with composite resin, and fissure sealant is applied to the surrounding pits and fissures. So placement technique is simple: caries removal, then the acid etching, bonding agent, composite filling, condensing, smoothing, and then sealant application, and finally polymerization. Now we have the atraumatic restorative treatment, or ART. So it is nothing but excavating dental caries using only hand instruments and restoring the cavity with adhesive restorative material. Usually GIC is used. It is commonly used in field conditions where we don't have electricity. Okay, in that conditions we have to use the hand instruments and we have to use a self-adhesive restorative material. So it is having a prevention and a curative approach. So it is very simple. We need to remove the caries using hand instrument, hatchet or spoon excavator, and fill it with the self-adhesive cement, that is GIC. So advantage, it's very biological approach. It is not in much invasive technique. It requires very minimal cavity preparation and there is no sound. Tooth tissues are removed. Less trauma to the dental tissues with low cost instrument, no electricity, less pain. Sterilization is very easy, and there are many disadvantages, just like we have for every treatment, that is, it is not possible for a tooth with pain or pulpal issues or a deep cavity or a periapical issues. Now we have the pit and fissure sealants, very commonly asked question. First, we need to know what is pit and fissure. Pit and fissure is a pit and fissure which is present on the occlusal surface. Pit and fissure sealants are sealants which is applied on these pit and fissures. So we have classification of pit and fissures, that is I, Y, J, K types. Whereas the sealant classification based on generation, first, second, third and fourth. First we have UV light, second is self-cure, third generation is blue light, and fourth is fluoride releasing. Then based on the filler content, unfilled and filled. Then we have based on the color, we have based on the chemical structures, that is MMA based, Tech DMA based, BPD, BIS GMA and PMA. So, difference in cavity preparation of primary and permanent teeth. Okay, anatomical features. Because we know all these things, we have already seen what are the differences between primary and permanent teeth. In pulp, where we have a larger pulp related to primary teeth, and pulp bones are too close to the surface. But the problem with these primary teeth, when we have a larger pulp, there is limited room for cavity preparations. It soon end up in pulpal opening, and roots are longer and more slender and more flared, associated with lots of accessory canals. So pulpectomy is actually difficult. Okay, so there is a difference between cavity preparation of primary and permanent teeth. So what are the matrix band in pediatric dentistry? We have very many classification: posterior, anterior, metallic, non-metallic, with retainer, without retainer, anatomical, non-anatomical, universal and unilateral. All are various classification: adult, pedo. Next question we have, what are the modifications of GAC? So first one is metal modified glass anomer, that is silver alloy admix. There is silver amalgam alloy particles mixed with glass particles, which improves the strength, which is known as miracle mix. It is commonly used for core buildup and also with people with high caries. But the problem is it's aesthetic. Because of this alloy content, it looks like blackish in color. Whereas Cermet is glass sintered with silver, improving resistance to abrasion. And it was a development of by sintering the metal and glass powder together, which gives strong bonding of the metal to the glass. Okay, and it has improved resistance to abrasion compared with GIC, and their flexural strength is also higher, but the strength is still insufficient to replace amalgam alloys, and their use should be confined to low stress bearing area cavity preparation. Whereas we have resin modified GIC, that is visible light cure or hybrid glass anomers. It was designed to produce favorable physical properties similar to those of resin composites while maintaining the basic features of conventional GIC. So this high strength, high velocity GIC, commonly used in art technique, we have seen in previous slides. It's a common example, very popular Ketak molar. The setting is very rapid and early moisture sensitivity is considerably reduced, and solubility in oral fluids is very low. Rubber dam, we have seen it in our endodontics. That is the most ideal method of in the isolation technique, where we have a good condition where we can do the restoration without any water contamination. So it provides a clean, dry operating field, clear access and visibility, improves properties of dental materials, and gives protection to the patient and operator, improves operating efficiency, prevents aspiration of fluids, prevents accidental ingestion of files, reamers, and prevent injury to soft tissues such as tongue, cheek, gingiva, and reduced patient's conversation. So it is made of basically latex material which is having size of 5 by 5 or 6 by 6, thickness thin, medium, heavy, extra heavy and special heavy. It can be green, blue or black, brown. It has a dull and bright surface. Because the dull surface should face the occlusional aspect as it reflects less light. Thicker material which resists tear and thinner ones pass through the tight approximal contact easily. Sorry about this question mark. And the steps in preparation and placement, that is dental dam equipment and supplies ready. Then the dam is punched, clamp is selected, ligated and positioned on forceps. Then the clamp is placed, then the dam is placed. After that, frame and dam secure on the frame. Now we have the zinc oxide eugenol, that is a cement which is very commonly used in pediatric dentistry. They are protective sedative lining on deep caries cavities for temporary filling, temporary cement, pulp capping, and also as a root canal filler, or it can be used as periodontal surgical packing. Depending on their use, they vary widely in their properties. In general, they are cements of low strength and least irritating of all dental cements, and they are known to have obtundent effect on exposed dentine. So that was about zinc oxide eugenol. So this session was a smaller session, and we have the pediatric endodontics in next session, and one more session will be there. So hope you had a quick review of the pediatric restorative dentistry. I will come up with the pediatric endodontics in my next session. Thank you.
Welcome back to the question paper discussion of pediatric dentistry. We are into the 8th part of the sessions. So this session deals about the pediatric endodontics, the most common essay question of any pediatric question paper. So the common questions we know: pulpotomy, pulpectomy, apexification, apexogenesis. So the first long essay is about pulpotomy. The definition, classification, indication, contraindication, and the various medicaments, its advantages and disadvantages, the difference between formocrosol and glutaraldehyde pulpotomy, and describing in detail about formocrosol pulpotomy. So Finn defined pulpotomy as a complete removal of coronal portion. Okay, it is just removing the coronal portion of the dental pulp. So we know dental pulp has coronal portion and the radicular portion. Radicular portion is nothing but the portion of the pulp which is present within the root, and coronal portion is the one which is present within the crown. We cannot say that it is present, it is a continuous structure, but we can technically speak coronal pulp and radicular pulp based on the CEJ. So pulpotomy is a removal of coronal portion of the dental pulp. After that, placement of a suitable dressing or medicament that will promote healing and preserve the vitality of the tooth. Okay, so we have basically two types of pulpotomy: vital and non-vital. In vital, we have devitalization type, preservation type, regeneration type, and mortal pulpotomy. In devitalization, we can have a single sitting and two stage. Single sitting, we can use formocrosol or laser. Two stage, we can use parafoam devitalizing paste. Preservation, zinc oxide eugenol, it has got preservative or preserving the biological tissues properties, so that properties will be used for preserving the structures. So the materials used are zinc oxide eugenol, glutaraldehyde, and ferric sulfide. Regeneration, it is different. It has the capability, that is calcium hydroxide, it has capability of regenerating like dentine. So it is regeneration pulpotomy. So MTA can be used, osteogenic protein can be used. Mortal pulpotomy, we can use beechwood cresol or formocresol, and non-vital pulpotomy. So what are the indications of pulpotomy? One is mechanical pulp exposure, teeth showing a large caries lesion but free of radicular pulpitis, basically the infection which is technically within the crown or the coronal pulp. And next indication, history of only spontaneous pain. Okay, hemorrhage from exposure, sides bright red, and it can be controlled. That means it's a limited hemorrhage. Then there is no absence of absence of abscess or fistula. It means there is no periapical or radicular infection. There is no bone loss, there is no interradicular radiolucency, and at least 2/3 of root length still present to ensure reasonable functional life, and young permanent tooth with vital exposed pulp and incomplete formed apices. Okay, so these are the indications of pulpotomy, where we try to retain the vitality of tooth and helps the tooth to rebuild the structures. That is, it can rebuild the apex, or it can form the closure of apical foramen. So we need to retain the radicular pulp in order to produce the structures at the apex. But contraindication, if we have a persistent toothache, that means the infection has spread in radicular pulp, then tenderness or percussion where the infection is likely to present on the periapex, then the root absorption where involving 1/3 of the root length, large caries lesion with non-restorable crown, highly viscous sluggish hemorrhage, not like bright red, and which is non-controllable. Medical contraindications like heart disease or immunocompromised patient, presence of fistula, presence of resorption, it can be external or internal, and mobility and calcification of pulp. In all these cases, pulpotomy is contraindicated. So what are the advantages of glutaraldehyde? So we can use many material. So what are the advantages of glutaraldehyde over formocresol? So glutaraldehyde is a bifunctional reagent which allows to form strong intra and intermolecular protein bonding, which leads to superior fixation by cross-linkage. It's an excellent antimicrobial agent, and it has got superior fixative properties, self-limiting penetration, it causes less necrosis, it causes less dystrophic calcification of pulp canal, less toxic, and it demonstrates less systemic distribution, it is slow tissue binding, readily metabolized, eliminated in urine, that is 90% in 3 days, and the mutagenicity and antigenicity is less compared to the formocresol. Okay, so these are the advantages of glutaraldehyde. Next thing is, what is the composition of formocresol? It is also known as Buckley's formula. The cresol is 35%, glycerol 15%, formaldehyde 19%, and water 31%. Its preparation, we use 1/5 concentration of Buckley's formula, which is prepared by the following method, that is, dilute 3 parts of glycerin and 1 part of water, that is 90 ml and 30 ml. This is 3 part and this is 1 part. So add 1 part of formocresol to 4 parts. We are creating 3 parts of glycerin, 1 part of diluted sterile water, then 1 part of formocresol to 4 part diluent. So this 30 ml formocresol will be added to 120 ml of diluent to obtain 150 ml of formocresol. So what are the histological changes happening? So immediately the pulp becomes fibrous and acidophilic, and after 7 to 14 days there will be 3 zones. The first one is zone of fixation, then a zone of atrophy which has poor cellular definition, then zone of inflammation which extending apically into the normal pulp tissue. After 1 year, there will be progressive apical movement of these zones, only with acidophilic zone left at the end of 1 year. Okay, so these are the histological changes happening. Next question, enumerate various pulp therapy procedures for primary teeth, indications of pulp therapy in children. discuss in detail about pulpectomy. Okay, so sometimes they'll simply ask any tooth. Don't get confused. The procedure is almost same for all the teeth. So what are the various pulp therapy procedures? That is direct pulp capping, indirect pulp capping, pulpotomy, apexogenesis, pulpectomy, and apexification. These four techniques where we can retain the wall vitality, and we can have a possibility of rebuilding the structures. I mean the formation of remaining part of the root or creation of a dentine or other vital structures, where pulpectomy and apexification where it's mostly done on non-vital teeth. So what are the indications of indirect pulp capping? When there is deep caries lesion which are close to but not involving the pulp in vital primary or young permanent teeth. Okay. So when pulp inflammation is seen as nominal and there is definite layer of affected dentine after removal of infected dentine. Whereas direct pulp capping, when we have a small mechanical exposure surrounded by sound dentine in asymptomatic vital primary teeth. Okay, indirect we are doing on a deep caries lesion, but direct we are doing on a mechanical exposure by using of a rotary instrument. So this exposure should have bright red hemorrhage, not like a dark red, which is indicating a deep lesion, which can be easily controlled by a dry cotton or pellet with minimal pressure, and through pinpoint exposure we can do direct pulp capping. So what are the indications of pulpotomy? Mechanical pulp exposure in primary teeth, large caries lesion but no radicular pulpitis, only spontaneous pain, hemorrhage from exposure site, bright red and which can be controlled, and absence of abscess or fistula. When we do apexogenesis, indicated in traumatized or pulpally involved vital permanent tooth, when root apex is incompletely formed, there is no history of spontaneous pain, no sensitivity on percussion. So what are the indications of pulpectomy? When we have uncontrolled pulpal hemorrhage, primary tooth in absence of its permanent successor, primary teeth with necrotic pulp and minimum of root resorption, when teeth with stomas, teeth in hemophiliacs, primary pulpless teeth when speech aesthetics are a factor, pulpless molars holding orthodontic appliance, all are pulpless teeth. Okay, so indications for apexification is on non-vital permanent teeth with open apex, which is also known as blunderbuss canal. Next we have pulpectomy. So we have two types of pulpectomy, that is single visit and multiple visit. In pulpectomy we remove entire pulp. So single visit pulpectomy, the procedure first is anesthetized and isolated access cavity is prepared, coronal and radicular pulp is removed, then using a file we take a file with IOPA, then filing done to enlarge the canals for condensing the filling material, then saline irrigation is done, then drying the canal, obturate the canal, pulpal and coronal portion place the final restorative material. It's nothing but root canal treatment on a primary teeth. So what we do, this single visit will be done on a one visit. Okay, whereas multiple visit pulpectomy, in first visit what we do is a first few procedures will be done and the remaining will be done on the second appointment. So first we do the anesthetization, isolation, access cavity, then the coronal and radicular pulp is removed. After that, formocrysol cotton pellet is placed in the chamber and keep a temporary restoration. And the second appointment, we call the patient after 5 to 7 days and remove that restoration, debride the canal, filing, irrigating, drying, and keeping a temporary restoration. So what are the pulp capping methods? So we have two types of pulp capping methods, indirect and direct. Okay. So indirect is defined as a procedure wherein small amount of caries dentin is retained in deep areas of cavity. So in order to avoid exposure of pulp, followed by placement of a suitable medicament and restorative material which seals off the caries dentin and encourages pulp recovery. So we have already seen the indications of direct and indirect pulp capping. So direct pulp capping, when there is a mechanical trauma or the exposure due to any rotary instrument. So we just place a medicament or non-medicated material on the pulp. Okay. So excavating the last portion of deep dentinal caries, and it is usually happens due to the trauma. So what are the medicaments we use? So the first one is calcium hydroxide. It is a white, crystalline, slightly soluble basic salt which dissociates into calcium and hydroxyl ion and exhibits high alkalinity. So it induces, that is the most important property, induce hard tissue formation. So it forms a dentine bridge when placed in contact with pulpal tissue. So it is a regenerative material. So next we have corticosteroids and antibiotics. Neomycin, hydrocortisone, ledamix or penicillin or vancomycin with calcium hydroxide can be used. Inert material like isobutyl cyanocrylate and tricalcium phosphate ceramic can be used. Direct bonding like total H material, a polygenic film can be laid over an exposure site without displacing pulp tissue and onto surrounding dentin. The adhesive film is cured by light and act as a barrier as a composite resin is gently spread over the pulp onto the surrounding dentin. Isobutyl cyanoacrylate used as a capping agent and proved to be an excellent hemostatic agent as well. A reparative dentin bridge simulator. Denatured albumin. This protein has calcium binding properties. If a pulp exposure is capped with protein, the protein may become matrix for calcification, thereby increasing the chance of biological obliteration. Then we have MTA, that is mineral trioxide aggregate. It does hard tissue formation in pulpal tissue, promotes rapid cell growth, produces a thicker dentinal bridge, less inflammation, less hyperemia, less pulpal necrosis. Collagen fibers is there. It influences mineralization and less irritant. 4 meta-adhesive, laser, bone morphogenic proteins, all are there. Now we need to study about epoxification. Epoxification, it is a method of inducing, okay, we are inducing apical closure through the formation of a mineralized tissue in the apical pulpal region of a non-vital tooth. This is the most important part, non-vital tooth. Okay, so we are creating or inducing apical closure, okay, of a non-vital tooth because the tooth has lost its vitality. It cannot create or apical closure by its own because of lack of pulpal tissue. So we are inducing it with an incompletely formed root and an open apex. So we can use zinc oxide, eugenol, tricalcium phosphate, MTA, calcium hydroxide or collagen calcium phosphate gel. So after root canal preparation, this calcium hydroxide powder is used to fill 2 mm short of radiographic apex. Then remaining canal is filled with calcium hydroxide mixed with saline. Barium sulfate may be added for radiopacity. Then calcium hydroxide ejected into pulp chamber. TF is applied after 6 to 24 months. Apexification is verified. If it is done, it will be followed by root canal treatment. So calcium hydroxide we already seen in detail. Some examples are pulpadent, dical, hydrex. So what is electrosurgical pulpotomy? So it is like same procedure but we are doing electrical method. So same like isolation and LA administration, caries removal. Cotton pellets will be kept. The high factor plus 797 set at 40% power and 705 ampere electrode used to deliver the electric arc. Then cotton removed and electrode placed 1 to 2 mm above the pulp. Electric arc allowed to bridge the gap for 1 second, followed by a cool down period of 5 seconds. Pulp stem dry and blackened, then pulp chamber filled with zinc oxide eugenol, final restoration. So pulp vitality test we already discussed. We already have a separate video. I'll put in the I button. The various types of pulp vitality test: cold test, the slow test, the temperature test, the test which is done by making a cavity. So many techniques are there. So all will be you can watch it in a separate video. So I'll be putting it in I button. So that was about pulp vitality test. So that was all about this session. So I'll be making 2 more sessions for this Pedodontic question papers. So this session was all about the pulpotomy, pulpectomy, apexification and apexogenesis. So first you need to understand the concept. So it will be easy. The procedures are almost same, little bit difference of the material. Pulpotomy is removal of coronal pulp. Pulpectomy is removal of complete pulp. Apexogenesis is creating apex by its own structures, its own pulp. Apexification, we are doing it on a non-vital tooth. So that's all about this session. I'll come up with the next session in pediatrics. Thank you. Hello everyone, welcome back to the last session of pediatric dentistry question paper. So this session deals about the gingiva and periodontium of Pedodontics, that is kids gingiva and periodontium and its features. The first question is about features of normal gingiva in children and classify the diseases of gingiva and periodontal structures and explain in detail on acute hepatic gingiva stomatitis. So normal gingiva in children, we know it is pale pink, smooth, thick and round. Free gingiva is keratinized and endodontal clefts with retrocuspid papillae. Sulcus depth would be 2.1 to 2.3 millimeter. The red alveolar mucosa and wider periodontal ligament. Collagen bundles are more hydrated and less differentiated. Ground substance, there is low ratio of collagen to ground substance. And fibers, gingival fibers are immature trabeculae, the thick trabeculae with large marrow spaces. So we can classify gingivitis as acute, chronic and gingivitis associated with systemic diseases. In acute we have hepatic gingivitis and necrotizing ulcerative gingivitis. In chronic we have with local contributing factor and without local contributing factor. So what is acute hepatic gingival stomatitis? It affects both gingiva and other parts of oral mucous membrane. It's commonly seen in children less than 3 years of age, caused by the herpes simplex virus type 1. It follows a series of fever such as malaria, measles and chickenpox. The onset is preceded by a prodromal period with symptoms such as irritability, malaise, vomiting and fever, and presence of small vesicles which rupture to reveal small yellowish painful ulcers with erythematous margins. And it is also associated with drooling of saliva, inability to chew and swallow, and the child may become increasingly uncooperative during tooth brushing because of this gingival inflammation and other associated symptoms. But the condition is self-limiting and the management is to encourage bed rest, provide plenty of fluid and maintain a good oral hygiene through general debridement. Analgesics can be prescribed to relieve the pain and application of mild topical anesthetic gel is recommended. So what is juvenile periodontitis, otherwise known as localized aggressive periodontitis or LAP? Very commonly asked question. It occurs in otherwise healthy children and adolescents without clinical evidence of any systemic disease. So it is characterized by rapid and severe loss of alveolar bone.
around more than one permanent tooth, especially the first molars and incisors. This also is a self-limiting disease, and retrospective data obtained from LAP patients suggests that the bone loss around the primary teeth can be an early finding of this particular disease. So next we have a long essay, that is children with special healthcare needs and their dental management, with that is children with cerebral palsy, and not add a small note on oral preventive care of the cerebral palsy children. So Frank and Winter classified the special healthcare needs as blind or partially sighted, deaf or partially deaf, educationally subnormal, epileptic, maladjusted, physically handicapped, defective of speech, and senile. New classifications: developmentally disabled or medically compromised. Agerholm classified an intrinsic handicap is one from which person cannot be separated, while an extrinsic handicap is one from which person can be removed, for example, social deprivation. So what are the oral preventive care for cerebral palsy? That is, patients should help brush their children's teeth after every meal, brush the tongue, since this will help prevent halitosis. Parents can help make children's teeth more decay resistant by using a children's toothpaste with the proper toothpaste and toothbrush. And up to age 3, parents should only use baby tooth cleanser to avoid fluorosis discoloration of the adult teeth. Children taking any oral medication should have their teeth cleaned after each dose of medication, because most of the medications containing sucrose, which increases the risk of developing dental caries. And children should have their first oral health evaluation by age of 12 months and or within 6 months of the eruption of first tooth. Same question being asked: describe the management of child with mild mental retardation. First, we need to give the family a brief idea of the office before attempting treatment, introduce the patient and family to the office staff. This will familiarize the patient with the personnel and reduce the patient's fear. Allow the patient to bring a favorite item, a stuffed animal, blanket, or toy to hold for the visit. Be repetitive, speak slowly and in simple terms. Alternative communication systems such as picture board or electronic device to assist with dental explanation and instruction should be there. Only give one instruction at a time. Reward the patient with compliments. Actively listen to the patient. They have trouble with communication, and the dentist should be very sensitive to gestures and verbal requests. And next, invite the parent to the operatory for assistance and to aid in communication with the patient. Keep appointment to a minimal time. Children with cerebral palsy may have a severe gag reflex that makes it difficult to take the dental radiographs. Slowly we can start from the basic procedure to more difficult procedure, that is anesthesia and restorative dentistry, once the patient has become accustomed to the dental environment. And always schedule the patient early in the day while the dentist staff and the patient will not be fatigued. So another classification we have NAVAX classification: physically handicapped, mentally handicapped, congenital, convulsive, communication, systemic, metabolic, osseous disorders, and malignant disorders. Again, the question of cerebral palsy was asked. So oral manifestation or common manifestation, we have, it's not oral manifestation, common manifestations of cerebral palsy: delayed milestones, muscle weakness, retention of primitive reflexes, apraxia, impaired cortical sensation, proprioception, or contractual deformities. Whereas oral manifestation, due to GERD, there is lots of dental erosion or loss of tooth structure, gingival overgrowth due to the seizure medication, and the tongue is hypertonic and cigar shaped. The tongue thrust during swallowing and speaking. Upper lip will be underdeveloped. It does not produce enough pressure on the front teeth to align them correctly. And the tongue, in athiotic cerebral palsy, the tongue shows spontaneous wave-like motions. Abrupt and wide opening of the mouth can lead to jaw dislocation. Uncoordinated movement of tongue, jaw, and face muscles will be there. And orofacial findings in hypotonic cerebral palsy, the tongue is large, flat, and protruded. Facial movements are weak, and the upper lip is inactive. So consider treating a patient who uses a wheelchair in the same itself. That is, if a patient is to be transferred to dental chair, ask about the preference for the mode of transfer. If the patient has no preference, the two-person can lift the patient to the clinic. Make an effort to stabilize the patient's head through all phases of this dental treatment. Try to place and maintain the patient at the midline of the dental chair with arms and legs as close to the body as feasible, and patient's back slightly elevated to minimize the swallowing. On placing the patient in the dental chair, determine the patient's degree of comfort and assess the position of the extremities. Do not force the limbs into unnatural positions, and we can use immobilization for controlling movements of the extremities, but should be very judiciously done. And for control of involuntary jaw movement, we can use mouth props and finger splint. And we should be careful that because these appliances may trigger strong gag reflexes and minimize the startle reflex reaction, such as abrupt movement, noises, and lights without forewarning the patient. And introduce the intraoral stimuli slowly to avoid eliciting a gag reflex. Okay, and because these cerebral palsy children have severe gag reflex, so we cannot take dental radiographs. So two modified radiographic techniques for use in children with cerebral palsy can be used, that is a 45-degree oblique head plate and the reverse bite wing. And always consider the use of rubber dam for restorative procedures, and work efficiently and minimize patient's time in the chair to decrease fatigue of the involved muscles. So what are the clinical presentations? Special consideration the management of children with Down syndrome, that is they are with IQ between 30 to 50. So where they have growth and skeletal abnormalities, prenatal, postnatal growth deficiency, and also a tendency towards premature birth. So their osseous maturation is delayed, brachycephaly and flat occiput, large fontanelles, delayed closure, frontal and sphenoidal sinuses may be absent, maxillary sinuses may be hypoplastic, there will be ocular hypoteliorism, small nose with flattening of the nasal bridge, relative mandibular prognathism, upward slanting of palpebral fissure. Then the ears, small, and the lips are broad, irregular, and fissured. The palate is narrower and shorter, but palatal height is not higher than that observed in the general population. Then there will be articulation defects. The voice is often hoarse, low pitched. Periodontitis will be there in 90% of the cases, but because of the severe saliva uh, presence, the dental caries might be low. Eruption of both deciduous and permanent teeth will be delayed. Irregular sequence of eruption. Malalignment of teeth is very common. Crossbite, mandibular overjet, occlusion, and reopen bite will be there. Management, we can have a pleasant, cheerful, affectionate, and cooperative dental procedures. We should work at a slower pace. We should emphasize on preventive dental care with frequent follow-up visits to monitor oral hygiene. Light sedation and immobilization may be indicative in those children who are moderately apprehensive, or we can try general anesthesia in severely resistant patients. Now, what are the medically compromised conditions in children? Management of children with factor A deficiency who requires extraction of a tooth. So the common medical compromise conditions are diabetes mellitus, leukemia, hemophilia, thrombocytic purpura, any congenital cardiac defects, acquired immunodeficiency syndrome. So hemophilia A, we know it is a hereditary genetical disorders where our body's ability to impair or control the bleeding is it is having a problem. The coagulation is impaired. So there will be frequent series of bleeding. Hematos common in these type of patients which is having symptoms associated such as pain, stiffness, and limited motion. Individuals may develop debilitating painful arthritis. Pseudo tumors might be there. So while giving local anesthesia, in the absence of factor replacement, periodontal ligament injections may be used. Infiltration anesthesia can generally be administered without a replacement therapy. A minimum of 40% factor correction is mandatory before a block anesthesia. Okay. For simple extraction, 30 to 40% factor is administered within 1 hour before dental treatment. Anti-fibrinolytic therapy should be there because these agents include epsilon amino caproic or tranexamic acid. In children, epsilon aminocaproic acid is given immediately before the dental treatment in an initial loading dose of 100 to 200 milligram by mouth. After that, 50 to 100 milligram per kg is administered every 6 hours for 5 to 7 days. So after extraction is done, the direct topical application of hemostatic agents such as bovine thrombin can be used. Topical thrombin may then be sprinkled over the wound, or direct pressure with gauze should be applied to the area. Next, we have the developmental anomalies, that is anomalies of teeth. This we have already seen or already studied regarding the number, regarding the shape. Number we have anodontia, hypodontia, micro, macro related to the size, position, structure related to the amelogenesis, dentinogenesis imperfecta, and regional odontodysplasia. Whereas the shape we have gemination, fusion, concrescence, dense invaginators, uh, then taurodontism, hypercementosis, many other dilaceration. So all need to be explained if it is asked as a long essay. Various classification of cleft lip and palate. So this is sometimes will be asked in the oral medicine, oral maxillofacial surgery, OMFS. So we use classification group 1, 2, 3 and 4. Group 1, cleft of the soft palate. Group 2, cleft of the hard and soft palate to the incisive foramen. Group 3, complete unilateral cleft of the soft, hard palate and lip, alveolar ridge on one side. Group 4, complete bilateral cleft of the soft, hard palate and lip and alveolar ridge on both sides. Davis and Ritchie's classification group 1, 2 and 3, prealveolar cleft, post-alveolar cleft and alveolar cleft. In prealveolar, lip cleft only with subdivision, unilateral medial and bilateral. In group 2, post-alveolar, degree of involvement of the soft and hard palate up to alveolar ridge and submucous clefts also included. Group 3, complete clefts of palate, alveolar ridge and subdivision of unilateral, medial and bilateral. Another classification, hair lip and cleft, isolated cleft of the palate given by Fogg Anderson in 1942. So this is Canham-Strips Y classification and Millard's modification of Y classification. This it looks like a Y. So we have lip, alveolus, palate anterior to the incisor foramen, again lip, alveolus, palate anterior to incisive foramen, right and left. Then we have anterior hard palate, then posterior hard palate and soft palate. It looks like a Y. Then we have a modification, that is coming nose and nasal floor, then lip, then alveolus, hard palate,
hard palate and soft palate. So we have the short notes anodontia. We already seen that is this no teeth present. We need to have a prosthetic rehabilitation. It is associated with ectodermal dysplasia. Enamel hyperplasia, we know it can be a generalized pattern, localized pattern, and smooth pattern, and also a rough pattern. So obturator plate, that is a feeding plate used from birth to 3 months. It's fabricated after taking impression and is made of acrylic. It should be cleaned before and after each feed. Adjustment of the obturator are done once the primary teeth erupts into oral cavity. Ankylosing, we know it is known as tongue tie. It's a congenital oral anomaly characterized by abnormal short lingual frenum. So partial fusion or in rare cases total fusion is there. It limits the range and motion of the tongue. It impairs the ability to fulfill its function. So Turner's hyperplasia is due to the trauma which is happening to the tooth, but because of the periapical inflammatory disease of the overlying deciduous tooth, this happens. We have in the next question, child abuse and neglect. Describe the battered child syndrome and the role of dental surgeon. So child abuse, according to Gill 1968, it is defined as non-accidental physical injury, minimal or fatal, inflicted upon children by a person caring for them. It is an overt act of commission of a caretaker, physical, emotional, or sexual. Neglected child, it is one who shows evidence of physical or mental health primarily due to failure on the part of the parent or caretaker to provide adequately for child's needs. The battered child syndrome, 1961, C. Henricum coined the term. He developed the term seeing children coming into emergency room with unexplained accidents. He rediscovered the child abuse. It took the profession 90 years to really confront the child maltreatment. So he and his colleagues developed the criteria for abuse and provided legitimacy to address the issues of child abuse. So what is the role of dentist in child abuse and neglect? So he can identify and prevent the child abuse as follows. Observe and examine any suspicious evidence that can be ascertained in a dental office. Record according to the law. If any dental injuries, should be acquainted with management of injuries to both primary and permanent dentition. To establish and maintain a professional therapeutic relationship with the family, and transfer the child to physician or hospital for proper care. So advances in pediatric dentistry, that is nanodentistry, it is the latest introduction to dentistry. It will make possible the maintenance of comprehensive oral health by employing nanomaterials, biotechnology, which includes tissue engineering and ultimately dental nanorobotics. It includes nanodiagnosis, nanomaterials, and nanorobotics. So that was all about Pedodontic question. It was a 9 session series. So hope you had watched all the previous 8 sessions. If not, do watch to get a grasp of all the previously question papers of Kerala University of Health Sciences. So I'll be uploading all the sessions in one session, which will be very much helpful for the exam going students. So I'll come up with another topic in dentistry and more. Thank you. Have a good day.